بعدين مش اوه اهل الفرح والحزن
دكتور محمد عم شذب الصوت، سمعني. بس عم شوف إذا سمعيني. أوكي. بس I believe you are hearing me, right? Thank you دكتور. أهلا وسهلا حضرتك دكتورة مها وبالجميع. نبلش؟ طيب. So, dear distinguished guests, faculty members, dear President of the Order of Pharmacists in Lebanon, dear deans, everyone, thank you really for coming. It wasn't easy what we went through all this week and even today. Thanks again. Also our colleagues that are entering via Zoom. Thank you for joining us. So after the success of our first pharmacogenomics and personalized medicine program event that took place in BAU last October, here are we today in the second session at Al Bustan Hotel Beit Miri, launching our master's degree. Today, we all mark a milestone in advancing personalized medicine in Lebanon, offering a unique educational program that will prepare the next generation of pharmacists and clinicians to lead in this cutting-edge field. Through the collaboration of BAU and our esteemed partners in Lebanon and abroad, especially in Egypt, we are pioneering the way forward in integrating pharmacogenomics into healthcare practice. It is a privilege to have you all here today as we embark in this journey toward precision medicine. Allow me to introduce a driving force behind this program. Our Dean, Professor Raja Fakhouri, the esteemed Dean of the Faculty of Health Science at BAU. Professor Fakhouri is a professor of medical biochemistry. She has completed her master's degree from the American University of Beirut, the medical school specifically, and did her PhD at Manchester University Medical School, and then her postdoctoral study at also Manchester University Medical School at the Department of Integrated Genomic Medical Research. After her graduation from Manchester University in 1993, she joined BAU, the Faculty of Pharmacy, and specifically the Department of Biochemistry and Pharmacology. Professor Fakhouri is the Dean of the Faculty of Health Sciences. She has published more than 50 papers in the field of molecular medicine and pharmacogenomics. It's my honor, our Dean, Professor Fakhouri, to have you here with us also today. And please come join us to deliver your welcome program. Thank you.
Thank you, Dr. Saeed, for the nice introduction. Thank you. طيب يعني عن جد الواحد يعجز عن الكلام بهيك مناسبة عن الوضع بالبلد أنا بتشكركم جدا إنه حضرتوا. بتشكر دكتور أحمد اللي إجا من مصر. يمكن لو ما جيت دكتور أحمد ما كنا كفينا. أنت اللي أعطيتنا الموتيفيشن إنه نجي. باسم رئيس جامعة بيروت العربية البروفيسور وائل عبد السلام والزملاء العمداء، وبرحب فيك نقيب. برحب بالزملاء اللي اجوا كمان من جامعات تانية، الجامعة اليسوعية والLAU لبنانيز أمريكان يونيفرسيتي، بكل الجاست اللي معنا، زملائنا طلابنا، أهلا وسهلا فيكم. بنرحب فيكم بظروف صعبة عم نحتفل بانطلاق برنامج جديد يونيك in the area. بنحكي هون لبنان والمنطقة. هلا التوين بروجرام تاعه بمصر، دكتور أحمد حيحكي عن هذا الموضوع. هالبرنامج هيدا انطلق هلا بسبتمبر بجامعة بيروت العربية بكلية الصيدلي. هيدا شغل 3 سنين مع البارتنرز تاعونا، وسنة قبل تحضير مع دكتور أحمد، يعني 4 سنين شغل. الحلو إنه هيدا البرنامج تحضر مع كلية العلوم الصحية وتسكن بكلية الصيدلة، فبعتبر إنه هيدا good example إنه بالفعل الجامعات التانية تتمثل فيه، لأنه حلو كتير إنه يكون في تعاون بين الكليات. هيدا الشغل البارتنرز تاعونا مثل ما شايفين هون وراي على البوستر. من بيوروب عنا اوبيدو يونيفرسيتي بسبين، كيل يونيفرسيتي بجرماني، نيوكاسل يونيفرسيتي بيوكي، الكساندرو بولي بجريس، وبمصر اكيد الدايركتور اوف ذا بروجكت دكتور احمد وحيد اللي هي جامعه الاسكندريه. وعندنا شركاء تانيين بمصر، مستشفى السرطان للاطفال، مؤسسه مجدي يعقوب، مؤسسه الالفي الفيوم، وكثير اذا بعتذر اذا نسيت حدا منهم، هلا دكتور احمد اكيد بيرجع بيذكرهم. وبلبنان عندنا اور بارتنر كمان الامريكان يونيفرسيتي اوف بيروت. So it is a collaboration with all these partners. نحن سعيدين كنا بهذا الشغل. نتمنى انه هذا الشغل يستمر دكتور احمد ان شاء الله بمشاريع تاني، لانه فعلا كان شغل ناجح اللي طلع منه برنامج ماستر بروجرام in pharmacogenomic and personalized medicine. بالتطور اللي صار بالقطاع الصحي وبالتعليم الميديكال اديوكيشن، وخاصة هلا مع الارتفيشال انتليجنس اكيد لازم نحن كمان يكون في تطور، والتطور باضافة برامج بحاجة الى السوق، بحاجة الى العالم، بحاجة الى القطاع الصحي اللي هو هذا البرنامج الفارماكوجينوميك اند بيرسوناليزد ميديسن. لانه بالفعل نحن الزملاء بيعرفوا، النقيب بيعرف انه ما فينا نوصف نفس الدواء لشخصين بيعانوا نفس المرض، لانه ممكن هالشخصين ما منهم مثل بعضهم 100%، لانه الجينيتيك ستراكشر تاعيتهم مختلف، الجينيتيك ميك اب تاعيتهم منا نفس الشيء. وبالتالي هيدا الشيء مش بس بيكلف كاست على البلد اللي عم يتعالجوها، ولكن كمان اذا نسينا موضوع الكاست هو موضوع سلامه المريض، لانه عم نعطيه دواء يمكن ما يناسبه، او يمكن الدوز ما تناسبه، او يمكن سايد افكت ما يناسبه. وبالفعل كثير عملنا انا وزميلي دكتور سعيد ريسيرش على كثير ستادي بينت انه مش كل الناس بيقدروا ياخذوا نفس الدوز تاع ستاتين او نفس النوع تاع ستاتين. واشتغلنا حتى على شغلات لها علاقه بالدايابيتس مع الميتفورمين انا وزميلي وطلاب من جامعه بيروت العربيه. هالطلاب هالبرنامج هيدا مثل ما قلت تسكن بكليه الصيدله بجامعه بيروت العربيه، لانه نحن فخورين انه عندنا كل الاكويبمنت اللازمه كريسيرش لاب بالكليه الصيدله، وعندنا اساتذه كفؤين، وحيكون في تعاون مع كليات ثانيه مثل كليه العلوم الصحيه وكليه الطب كمان. وطبعا حيكون في تعاون حتى مع زملائنا اللي موجودين بالاسكندريه، ان كان بالاشراف ولا كان بالتعاون مع الجامعه الامريكيه ببيروت كمان. في لاب تجهز من الإراسمس بلس لكل التكنيك اللي ممكن نحتاجهم بهذا المجال. بنتمنى شي مرة إن شاء الله نقدر يكون في تعاون مع الجامعات الثانية بهالبحث، يعني يكون في عنا ريسيرش كولابوريشن أو كو سوبرفيجن مع بقية الجامعات مثل الجامعة اليسوعية أو الجامعة اللبنانيز أمريكان يونيفرسيتي. هدفنا مش بس انه نحن نستقطب طلاب من لبنان، هدف هذا البرنامج انه بما انه قلت انه اتس يونيك بالمنطقه، فبنستقطب طلاب من خارج لبنان كمان، وان شاء الله الوضع بيسمح مع كل الظروف اللي عم نمرق فيها بالبلد وبالمنطقه. جامعتنا جامعه بيروت العربيه دائما حريصه على انها تضلها بالتوب رانكينج بالجامعات، ان كان كيو اس رانكينج ولا كي اتش اي رانكينج. وهذا الشيء من خلال البحث العلمي ومن خلال انشاء برامج متعدده، ان كان على الاندر جراجويت او البوست جراجويت اللي بتلبي حاجه السوق، والابحاث تاعتنا بتلبي حاجه البلد. ف... ف... ومن هيك صار في هيدا البرنامج اللي كان sponsored by the Erasmus Plus. أنا ما بدي أطول عليكم كثير، أكيد دكتور عبد الله حيحكي أكثر على البرنامج، دكتورة هانت حتحكي على هذا، بس بتسمحوا لي إني أتشكر أول شيء دكتور أحمد وحيد دايركتور أوف ذا بروجكت. كان الفضل الأول له إنه نحن هذا البرنامج أو هذا المشروع لقى النور وتحقق هذا البرنامج، والحمد لله بلشنا فيه بجامعة بيروت العربية بكلية الصيدلة وبكلية الصيدلة بجامعة الإسكندرية. هلا بنفس الوقت حينطلق البرنامج بسبتمبر بالجامعتين. وبدي اتشكر زميلي دكتور عن جد شهادتي فيه كثير مجروحة، دكتور سعيد شميل، لأنه هو بالفعل يعني قام بالشغل الكبير بهالمشروع. وبس كانت فرصة حلوة إنه اشتغلنا مع هالفريق المميز. واسمحوا لي أخيرا أتشكر الأورجنايزنج كوميتي اللي اليوم تعبوا كثير وحضروا كثير. صحيح ما في عدد كبير، ولكن مثل ما قالت فيروز بدنا نكمل باللي بقيوا، كتار قليل بدنا نكمل باللي بقيوا، فحنكمل. لبنان ما بيوقع، لبنان ما بيوقف شغل، لبنان ما بينكسر. فان شاء الله دائما نكون مجتمعين هيك بايفنتس لها علاقه بمصلحه بفائده البلد، مش باشياء ثانيه طبعا نحن كلنا ضدها. فثانك يو فور كومينج، وان شاء الله بيكون ايفنت يا رب سكسسفul. تفضلوا.
Thank you, Dr. Raja. So our next speaker is the Dean of the Faculty of Pharmacy, Professor Abdullah La'ani, who's a main stakeholder of pharmacies and also a significant player in pharmacogenomics in Lebanon. Professor La'ani got his PhD in 1991 from the Faculty of Pharmacy, University of Alexandria, Egypt, and was promoted to professor rank in 2004. His field of study is the chemistry of natural products, He has published more than 70 articles and supervised more than 25 master's and PhD theses. Since he was appointed as the Vice Dean of Education and Students Affairs in 2005, Professor Laani has supported the role of academic staff and students and considered their feedback during the enhancement of all related faculty affairs. In 2008, Professor Laani became the Dean of the Faculty of Pharmacy at BAU Lebanon. During his mandate, Professor Laani led the transformation of the curriculum of the faculty from an outcome-based curriculum into a modern, hybrid, and well-defined integrated competency-based curriculum, CBC, with particular focus on patient care and professional standards. In addition to the curricular enhancement, Professor Laani established the PharmD program, developed the experimental learning program, and introduced the IPE module not only in the curriculum of the Faculty of Pharmacy, but also in the medical faculty's curriculum. Professor Laani led the Faculty of Pharmacy to obtain the unconditional international accreditation from the Canadian Council of Accreditation of Pharmacy Program, CAP, for 5 years to the Faculty of Undergraduate Program. Please join me in welcoming Professor Laani.
سعيد ال presentation.
هتفتح بس فتحت فيها سكرين اذا
تمام ننزل من هنا. لا بترجع Okay. Thank you, Dr. Saeed, for the introduction. First, I would like to welcome Dr. Ahmed Wahid, and I would like to thank him for mastering the implementation of the whole program. And I would like also to thank Professor Rajaa Fakhoury, the Dean of Faculty of Health Sciences, and Dr. Saeed Shamia for their unlimited efforts done to bring this project to reality. I would like also to thank Dr. Professor Azza Abdelkader for her efforts in approaching the real program with our postgraduate program. She did a lot of work in this concern. I would like also to thank Professor Wael Nabil Abdessalam, the university president, for his unlimited support in implementing this master degree. Now, the title of my speech is Pharmacogenomics for Healthcare Professionals in Lebanon and in MENA region. It is well known that populations exhibit significant genetic variations due to many factors, including ethnic backgrounds and historical migrations. This genetic diversity impacts how individuals respond to medications, and it can also affect both the efficacy and safety of drugs. Accordingly, efforts aiming to understand genetic predispositions are going on in order to optimize drug therapy. This is pharmacogenomics that can be simply defined as a tailored approach to treatment based on individual's genetic profile. It involves the investigation of impact of an individual's genetic makeup on their responses to medications. This means that we are going to move from traditional treatment to personalized plans that consider genetic factors. This way, we can certainly reduce trial and error in prescribing medications and minimizing side effects. Moreover, embracing pharmacogenomics means staying at the forefront of medical innovation and being better equipped to meet patient needs. it is evident that MENA region is witnessing an increase in chronic conditions such as cardiovascular diseases, diabetes, and cancer. These diseases often require long-term medication and polypharmacy, where drug efficacy and safety are paramount. Addressing the unique genetic and the cultural landscape of the region, pharmacogenomics will offer more personalized and effective healthcare, improving patient outcomes and reducing healthcare costs. Let's first take a look at what is happening in advanced countries where pharmacogenomics and personalized medicine have advanced a great deal and gained significant traction in healthcare system. I will start with Canada. Canada is steadily incorporating pharmacogenomics into its healthcare system with key initiative entitled Canadian Pharmacogenomics Network for Drug Safety, CPNDS, which aim to avoid adverse drug reactions in children. The Canadian government also actively supports pharmacogenomic research. In addition, there is a focus on training healthcare professionals in genetic testing and personalized medicine. However, they have limited access to genetic testing in some regions and variability in the adoption of pharmacogenomics practices across provinces. Moreover, there is a greater need for education and awareness among healthcare providers. The second example is the United Kingdom, which is at the forefront of the precision medicine movement with 100,000 genomes project that has successfully integrated pharmacogenomics into the National Health Service. They offer healthcare professionals the tools to use genetic information in prescribing medications. They also established pharmacogenomics guidelines and educational programs for clinicians. Again, however, they have some challenges, including ensuring consistent access to genetic testing across the country and maintaining patient confidentiality with the increasing use of genetic data. The last example is the United States, which is a global leader in pharmacogenomics with extensive research and clinical applications. They have research programs aiming to build a diverse genetic database to support personalized medicine. They also have pharmacogenomic testing that is increasingly integrated into electronic health records, thus enhancing the accessibility for clinicians. Despite advancement, there are disparities in access to pharmacogenomic testing that are influenced by insurance coverage, socioeconomic factors, and regional differences. I will briefly compare between MENA region and the advanced countries to help identify actions needed to reduce the gap and to advance the implementation of pharmacogenomics and personalized medicine in the region. While the advanced countries have established the infrastructure, regulatory frameworks, and national initiatives supporting pharmacogenomics, Lebanon and the MENA region face challenges such as limited access to advanced laboratories and the facilities, genetic testing, and the trained personnel. In the MENA region, the investment in pharmacogenomics research lags behind that in aforementioned countries. However, some countries in the MENA region are making efforts to develop genomic research centers and incorporate pharmacogenomics into healthcare. Healthcare professionals in advanced countries benefit from the established pharmacogenomics education and the training programs integrated into medical and pharmacy curriculum. In contrast, in the MENA region, we are badly in need for education and awareness among healthcare providers. Ethical implications of pharmacogenomics, such as privacy, consents, and data security, should be highly appreciated by all. In our region, we might face additional cultural sensitivities. Despite the aforementioned challenges facing our region in adopting pharmacogenomics, there is significant potential for growth that could accelerate progress in this regard. Examples: collaboration with international research initiatives and adopting best practices from advanced countries, building partnerships with the established pharmacogenomic programs in other countries. We need also to concentrate our efforts in focus areas such as knowledge transfer, investment in infrastructure, and the development of regional centers of excellence in pharmacogenomics. As the field evolves, it is crucial for professionals in Lebanon and in the MENA region to engage with ongoing research, participate in training programs, and advocate for the needed infrastructure and policy support to fully realize pharmacogenomics potentials in improving healthcare. Accordingly, the following actions should be considered. Engaging with international programs and funding bodies such as Erasmus Plus is essential for advancing pharmacogenomics. Securing support and resources from these initiatives can help establishing the needed infrastructure and integrate global best practices and drive progress in the region, like in case of our current program. Raising awareness among healthcare professionals to better utilize genetic information in patient care and drive adoption of personalized medicine. Integrating pharmacogenomics into pharmacy curricula at universities to prepare future pharmacists with the knowledge and the skills needed for this evolving field. Early education will ensure that new professionals are well equipped to implement pharmacogenomics practices. National support from ministries of public health and the other governmental bodies is essential and vital. Policy initiatives and funding at the national level will facilitate the development and implementation of pharmacogenomics programs. Finally, establishing in each country a national central pharmacogenomic laboratory to provide a dedicated facility for research, testing, and data collection. This central laboratory will support standardization, improve access to genetic testing, and enhance the overall effectiveness of pharmacogenomics in the region. Thank you.
Thank you, Professor La'ani. Our third speaker is the Dean of Graduate Studies and Research, Professor Hadia Naqash. Professor Naqash is an accomplished academic leader with over 25 years of experience in higher education, specializing in physiology and pharmacology. Currently serving as the Dean of Graduate Studies and Research at BAU, Professor Naqash has played a pivotal role in enhancing the postgraduate system, establishing research infrastructure, and fostering collaborations both nationally and internationally. Professor Naqash earned her PhD in physiology and pharmacology from the University of New South Wales in 1995, following a master's degree in human physiology and bachelor degree in biology from AUB. Professor Naqash's extensive career includes significant contributions to accreditation processes, strategic planning, and research initiatives, leading to notable achievements such as the improving of the university's global ranking and establishing various collaborative agreements with prestigious institutions. As a dedicated educator, Professor Naqash has supervised numerous PhD and master students, emphasizing the importance of quality research and multidisciplinary collaboration. Professor Naqash is actively involved in various committees that influence higher education policy in Lebanon and has participated in multiple European Union-funded projects aimed at enhancing education standards and transparency. She is also recognized for her leadership in advancing quality education and research at Big AU, making a lasting impact in the field. Professor Naash, the floor is yours. Please join me with the presentation.
Good day, all. My note, or my word, was supposed to be a cheerful note. However, despite the sorrowful situation that we are passing through, however, we aim for the culture of life. It's not the culture of death that we aim for. My condolences go towards the life that has been lost. Yet nevertheless, we are called as a phoenix. Out of ashes we rise. It's life that we seek and the life that we aim for. That's why we're here together to celebrate the launching of a new program or a master program or the birth of a new program, because this is what we're good at. We're being positive. We continue to live in the way we want to. So good day to all of you. It's with great excitement that I stand before you today as a Dean of Graduate Studies and Research to celebrate a significant milestone in our university's commitment to advancing education and research in the ever-evolving field of healthcare. Today, I'm especially proud to introduce our newest program, Master in Pharmacogenomics and Personalized Medicine, that not only embodies our commitment to innovation, but is also the first in its kind in the Arab region. Although closely related master's programs have already been established in countries across the Gulf, such as in Bahrain and UAE, from drug discovery in the Gulf, none has gone as far as we in addressing the entire spectrum, from drug discovery to therapy development. What truly sets our program apart is its holistic approach. It spans the journey from drug development to clinical application, preparing our students and not just to understand pharmacogenomics in isolation, but to integrate it with broader therapeutic strategies. This innovative program is designed to equip our students with the knowledge and skills necessary to navigate the complexities of personalized healthcare in an age where no one size fits all. Pharmacogenomics, the study of how genes affect a person's response to drug, has the potential to revolutionize the way we approach treatment. By understanding the genetic factors that influence the drug efficacy and safety, our graduate will be at the forefront of developing tailored therapies that optimize patient outcomes. This program not only addresses a critical need in the healthcare landscape, but also reflects our university's dedication to interdisciplinary collaboration. Students will engage with experts from various fields, including genetics, pharmacology, and clinical practice, ensuring a comprehensive educational experience. As we launch this program, or as this program is birthed, we are committed to fostering an environment of research and innovation. Our faculty, who are leaders in their field, will guide students in exploring cutting-edge research opportunities and real-world application of pharmacogenomics. Thank you for attention. Thank you for coming here. We need to be positive. We need to go on. As I said, we are a phoenix and we'll continue our journey. Let us look forward to the exciting journey ahead with a Master in Pharmacogenomics and Personalized Medicine. I'd just like to thank everyone who was involved in this program. It is really a revolutionized program that we are presenting. I hope all the best. Thank you.
Hello. Our fourth speaker, Dr. Joe Saloom. Dr. Saloom is the president of the Lebanese Order of Pharmacists. He is actively involved in addressing issues related to the pharmaceutical sector in Lebanon, including combating corruption and protecting the integrity of pharmaceutical practices. Dr. Saloom has been vocal about the challenges facing the pharmaceutical industry in Lebanon, such as the falsification of expiration dates on medications and the economic difficulties pharmacies face due to the currency fluctuations and drug subsidies. Dr. Saloom, the floor is all yours.
صباح الخير. من سخرية القدر أنه نحن اليوم عم ننبش عن آفاق جديدة في القطاع الصيدلاني والصحي وتعزيز دور العاملين في القطاع الصحي، في حين أنه أهلنا في الجنوب والبقاع وعدة مناطق من لبنان عم بيعانوا الأمرين، وعم بيعانوا الهجرة القسرية والعدوان الإسرائيلي المجرم. فبداية تحية لكل شهيد، تحية لكل إنسان مناضل من لبنان، وكلنا سوا مناضلين لأجل البلد اللي بنحبه، لاستعادة كرامته وسيادته ووحدة أراضيه. اللي عم بيصير اليوم هو مواكبة لدور ونظرية وتوجه نقابة صيادلة لبنان. من أول نهار استلمت فيها نائبة الصيادلة، هدفي كان خلق فرص عمل جديدة للصيادلة، ومن هون كان عملنا على إقرار قانون الصيدلة السريري كلينيكال فارماسي، بالإضافة إلى عدد الفرص العمل اللي بيخلقها بيعزز دور الصيدلة في القطاع الصحي، وبيساهم بتخفيض الفاتورة الدوائية ونوعية الدواء والعلاج الصحي في لبنان. وقفنا بوجه تهريب الدواء المهرب والمزور والصيدليات الغير شرعية ونوعية الدواء المتدنية في لبنان. وآخرها كان عندنا وقفة بوجه إحدى كبرى عملية بدي سميها الفساد بتغيير تواريخ صلاحيات أدوية منتهية الصلاحية، وواجهناها. بالتالي اليوم هو مواكبة لدور نقابة الصيادلة ونضال نقابة الصيادلة. الفارماكوجينومكس هي أفزة نوعية بعالم الصيدلة وعالم القطاع الصحي، وبيكون الصيدلة اليوم والمنخرطين بهذا المجال هن منخرطين في المنظومة الصحية بامتياز، منخرطين في تحسين نوعية العلاج وأفزة نوعية في تحسين نوعية العلاج. بدي أشكر دكتور سعيد على هيدا الإنجاز وعلى مجهوده، وكذلك دكتور أحمد اللي خصيصا جاي من مصر، وإن شاء الله كمان يكون حامل معه أخبار تاني بمخص البلد، لأنه بنعرف أنه مصر اليوم هي عم تلعب دور في الواقع العربي المتدهور، فإن شاء الله كمان يكون حامل كمان أخبار إيجابية. بدي أشكر أصدقائي العمداء دكتور عبد الله، دكتور هادية، دكتور رجاء، والأساتذة الكرام وكل المشاركين من كل الجامعات بهذا الحدث. إن شاء الله هذا المؤتمر يكون انطلاقة جديدة وفيل حلو لهذا البلد في ظل المشهدية السوداوية اللي عم نعيشها. وشكرا.
Our next speaker is Professor Ahmed Wahid. Dr. Wahid is currently a professor of biochemistry and molecular biology at the Faculty of Pharmacy, Alexandria University. In 2018, Dr. Wahid founded the Pharmaceutical Biochemistry Department at the Faculty of Pharmacy, Alexandria University. He also established the first molecular biology research lab in the department in 2021, in addition to the biomarkers lab in 2023. Dr. Wahid was appointed as a counselor of the International Union of Basic and Clinical Pharmacology Education Section. Currently, Dr. Wahid is serving as an expert in the Science and Technology Development Fund, main Egyptian national funding body. Dr. Wahid, the floor is yours.
طيب على بال ما البرزنتيشن تجهز. So no native English speakers are among the audience, right? Okay, so أنا يعني أحب أتكلم عربي بقى. براحتي. أولاً أنا أحب أشكر دكتورة رجاء، دكتور سعيد، دكتور عبد الله اللقاني، دكتورة عزة، البي إي يو كلها، دكتورة هانيا، الهيروز اللي من وراء الكواليس، وأنا أشكر الحضور إنكم جيتوا رغم الظروف الصعبة. ربنا يعني يكون في عونكم وستي سيف إن شاء الله. أنا جاي من مصر، أنا مش خايف، وأتمنى الناس كلها تبقى هنا برضو كده إن شاء الله. يعني إحنا رغم ان جايين نحتفل النهارده بحدث مهم، ان احنا هنعمل لونشنج للبرنامج بتاعنا في لبنان، ده برضو رسالة ومسج ان life goes on ومش هتقف ابدا ان شاء الله مهما يحصل باذن الله. اهلا بك. طيب مبدئيا كده النهارده ان شاء الله هيبقى احتفال باللونش بالبرنامج بتاعنا. المفروض ان التوين بروجرام بتاعه اللي كان في ايجيبت اوريدي لونشد من كام شهر فاتوا، بس كنا عملنا الدبلومه وهيبان كمان شويه النهارده. ان شاء الله الاسبوع الجاي هيبقى اللونش بتاع الماستر ديجري في اسكندريه ان شاء الله. طيب، ففارماسيوتيكال فارماكوجينومكس بروجرام بروجرام فور ذا فيوتشر. سو انا اعتقد ان شاء الله البروجرام ده هو انوفيتيف وهيبقى له شأن في المستقبل القريب ان شاء الله. طبعا لا اخفي سرا ان اكاديميه البحث العلمي في مصر وصلها مستثمرين هنود فعلا، وبداوا يدوروا على الجينيتك تيستنج والمعامل في مصر عامله ازاي، وبيستطلعوا امكانيه ان هم يخشوا السوق المصري. وكانوا بيقولوا لنا هم ما كانوش يعرفوا ان الاكاديميه البحث العلمي فيها ناس شركاء معانا في المشروع ممثلين لجامعه النيل، ان كانوا بيقولوا لنا ان ده البومينج بزنس الفتره الجايه. فالنهارده انا حابب طبعا انا شكرا على التقديم الجميل. انا يعني استاذ ورئيس قسم في الكيمياء الحيويه في جامعه اسكندريه. جامعه اسكندريه في النورث كوست اوف ايجيبت، اكيد اغلبكم يعرفها يعني. طيب النهارده هندي انترودكشن سريعه، اوفر فيو اوف ذا بروجكت ورك باكجز كانترودكشن. سو وات از فارماكوجينومكس؟ انا دايما بحب ابتدي بالابوقراط قالوا من 500 سنه: it is more important to know what sort of person has a disease. تدرس المريض نفسه اهم من انك تدرس المرض سايد باي سايد يعني. طبعا الفارماكوجينومكس طول عمرها موجوده، بقالها من بدات الكويند نفسه الاكسبريشن من الخمسينات، اواخر الخمسينات في القرن الماضي. ولكن من ساعه ما حصل اعلان للايجيبشن اسف الهيومن جينوم بروجكت في سنه 2001، وزي ما انتم شايفين في الصوره كان كلينتون وكان توني بلير وكان عميد معهد ال NIH اكبر جهه بحثيه في العالم، عملوا مؤتمر صحفي واعلنوا عن ان البروجكت ده ابتدى ولونشد وخلص في 2003. طبعا الفكره بتاعت الفارماكوجينومكس قايمه على استخدام الجينات. فمن ساعتها الفارماكوجينومكس طبعا حصل لها انفجار معرفي، تصاعد لحد ما وصل اللي احنا واقفين النهارده. سو وات از فارماكوجينومكس؟ هو ببساطه من غير الدخول في تفاصيل علميه عميقه، هو احنا على طول بندي الدراجز اكوردنج للديزيز. طيب ما احنا مش واخدين بالنا ان في فاكتور مش محمول حسابه خالص، اللي هو الجينز، الجيناتيك بروفايل بتاعنا. طبعا بتلعب دور بقى الجيناتيك بروفايل ده في الفارماكوكينetics وفي الفارماكوداينامكس بدون الدخول في تفاصيل علميه عميقه يعني. طيب وات از فارماكوجينetics؟ لان ساعات الاثنين تيرمز دول اكستشينجبل. فارماكوجينetics سب جروب من الفارماكوجينومكس. الجينومكس بتكلم على جينات كتير، شعب بحاله بندرسه باستخدام كمبيوتر سيستمز عملاقه. فارماكوجينetics جين او اثنين، وده غالبا اللي بيتم في المعامل البحثيه. طيب الفكره كلها ان احنا مختلفين 0.1% في الدي ان اي ميك اب بتاعنا، يت ان الكميه البسيطه جدا دي او النسبه البسيطه جدا دي بتعمل بيج ديفرنس في الديزيز سسبتبيليتي والديزيز بروجريشن، والاهم كصيدلي في الريسبونس تو ديفرنت ثيرابيوتيك انترفنشنز. طيب احنا ايه الوضع اللي احنا موجودين عليه النهارده؟ اغلب الدراجز الريسبونس بتاعها 60-70%. احنا عايزين يبقى 100%. طب ليه الريسبونس مش 100% حاليا؟ ليه؟ لان احنا مش زي بعض، الجينز مختلفه. في ناس بتعمل الميتابوليزم بتاعهم فاست، وناس تانية سلو ميتابوليزم. فاحنا كلنا عايزين نبقى في الجروب البيضاء دي، حيث ان دراجز نوت توكسيك ات اول وبينيفيشال بنسبه 100%. ومحدش عايز يبقى في الجروب الحمراء، الدراجز اللي بتتاخد بتبقى توكسيك فقط ومفيش اي بينيفيشري افكت ليها. طب انا عايز برضو ادي مثال بالوارفرين حاليا. ده يعني اثبت لكم ان الفارماكوجينومكس دي حاجه مهمه جدا. يعني لك ان تتخيل ان دي واقعه حقيقيه حصلت في مستشفى اسكندريه. دي الثيرابيوتيك ويندو بتاع الوارفرين كانتي كواجولانت. المفروض دي كانت في النورمال بيرسون. دي الثيرابيوتيك ويندو بتاعت شخص حامل للنيوتن جين C2C9، ودي ثيرابيوتيك ويندو بتاعت شخص حامل للدي بي او ار سي 1. طيب لك ان تتخيل ان حضرتك هتدي نفس الدوز بتاعت النورمال للشخص ده، هيحصل له اوفر انتي كوagulation، وهتدي نفس الدوز للشخص ده هيحصل له اندر. ما تتحركش.
يس مش هتتحرك. يس قالت لي هلا
هيحصل له اندر انتي كواجوليشن. ودي كانت واقعه حقيقيه في 2016. المريض دخل الاي سي يو يونت فعلا، الراجل الطبيب بيدي له جرعه مظبوط زي ما الكتاب الجايد لاين بيقول بالظبط. المريض ما بيتحسنش، بالعكس حالته بتسوء، ودخل الاي سي يو قرب خلاص كان يعني يتوفى، لولا ربنا كان فاتح على الطبيب المعالج في المستشفى في جامعه اسكندريه. ف فقال له لا انت تروح تحلل لي الجين ده، شوف الجين ده عندك مظبوط ولا لا. فلما حلله طلع فعلا في ميوتيشن مش سليم. ف ف فغير الدوز بتاعته خالص. طيب واقعة طريفة دايما احب اقولها، اوزي اوسبورن ده مغني روك انجليزي. طبعا الناس اللي راحت انجلترا قبل كده هتبقى عارفاه. فهم البريتش جينو بروجكت بدأ في سنة 2013 وخلص في 2018 متهيألي. فهو من ضمن البريتش جينو بروجكت كانوا بيحللوا المشاهير بتوعهم. فالراجل ده كانوا شايفينه صحته كويسة جدا، رغم انه اياميها كان عنده ستينات حاجة و60 سنة. فاكتشفوا ان عنده الجينز بتاعته بتعمل يعني بتكسر الريكريشنال والريكريشنال دراجز والانفيتامينز والمخدرات بطريقه اب نورمال. هم حتى كانوا بيقولوا we have never seen like these genes before. طبعا الجينز بتاعته كانت مختلفه. اذا فالجول اوف personalized medicine right dose of the right drug for the right indication at the right for the right patient at the right time. طبعا من 2017 بعد بقى ما الريسيرش بقى خد حده واتطور شويه، بقى في 200 مستشفى حول العالم بيطبقوا الموضوع ده. منهم واحنا لينا الفخر ان 357 هي المستشفى تقريبا الوحيده اللي في مصر يكاد يكون اللي بتطبقه. بس على الاقل احنا لينا سبوت. From this point طبعا روش وإيلومينا دول شركات مالتي ناشونال عملاقه جدا جدا، لقطوا طرف الخيط وقال لك بس احنا هننزل كيتس في السوق، والكيتس دي بقى يعني هتخلي الناس يعرفوا بقى امراض المستقبل المحتمله. وكانت واقعه انجلينا جولي لما راحت تحلل وعملت بريستكتومي وهو الى اخره. وقال تو بي اونست ات ذيس بوينت انا كمان طلعت طرف الخيط في 2018، قلت الله طب ما احنا يلا بينا نعمل بروجكت في القصه دي. طبعا احنا في 2022 من السنه اللي قبل اللي فاتت حوالي 6 بليون دولار. ده حجم الاندستري اللي في العالم كله. دلوقتي احنا بنتكلم في 12 بليون دولار في سنتين، يعني العمليه اتضاعفت في سنتين بس، ومتوقع ان تزيد بنسبه حوالي 8.5% في الكام سنه الجايين. طيب ايه الوضع الاكاديمي اللي موجود في امريكا مثلا، بما ان هي اكبر دوله متقدمه في العالم؟ وكان دايما الانجليز في الراديو الانجليزي كان يقول لك the strongest nation upon earth. 92% من كليات الصيدله في الولايات المتحده already incorporate pharmacogenomics في الاندر جراديويت كوريكولا، بس على سكيل صغير جدا، لمحه كده. مش كده وبس، ده في أربعة ساينتفك بوديز كبار في الولايات المتحدة بينصحوا إن الفارماكوجينوميك تيستينج should be performed as needed and used for medication therapy. قال لك لازم تستخدم الفارماكوجينومكس ولازم تستخدمه في العلاج بتاعه. طيب جميل. الحلو بقى اللي دايما انا اعمل ابديت للبرزنتيشن بتاعتي، فمن اسبوعين بس ويمكن اقل من اسبوعين ابو ظبي يعني اماره ابو ظبي قررت ان لازم يبقى المقبلين على الزواج من الاماراتيين لازم في اماره ابو ظبي لازم يعملوا مانداتوري جيناتيك تيستنج، فالعمليه بتتحرك بسرعه جدا. طيب الحلو اللي في الموضوع زي ما يعني فعلا في اخبار من مصر ان صحيح الدنيا بتتحرك ببطء بس في حركه. وزاره الصحه المصريه والاي دي اي المصري، الاي دي اي ده مكافئ للاف دي اي الامريكي، الاي دي اي المصري ووزاره الصحه المصريه في اكتوبر 22 بقى لهم سنه ونص منزلين تحذير الايرينوتيكان. ده المفروض دواء بيستخدم في يعني انتي كانسر. بيحذروا ان الناس في ناس معينه الجينات بتاعتها ممكن ما تستحملش سايد افكت ولازم يتراعى تغيير الدوز له اللي هو يعني فارماكوجينيتكس. بدات وزاره الصحه المصريه بالتعاون مع الاي دي اي يحسوا بحاجه زي كده، وده خبر جميل لينا طبعا. واحنا بنشتغل لقينا برضو الايجيبشن جينوم بروجكت انطلق مع وبعده بسنه السعودي جينو بروجكت، وبعده وفي نفس الوقت القطري جينوم بروجكت، فالمنطقه الايرانيان جينوم بروجكت كله بقى يتحرك. فيعني كل الكلام ده خلينا لا ده احنا لازم نتحرك احنا كمان. اذا فالاوفر فيو، فطبعا يعني انا جات لي الفكره دي الحمد لله من قبل ما الدنيا تتحرك. ده هو في 2018 لما كتبنا المشروع وقدمناه لاول مره ما كانش التحركات دي كلها حصلت. فالحمد لله دلوقتي زي ما انتم شايفين حركه كبيره. البروجكت بتاعنا هو according للإرازموس بلس ديفينيشن هو ريجونال بروجكت، هو بروجكت حوض بحر الابيض المتوسط وليس انترناشونال فقط. جامعه اسكندريه الاعضاء، جامعه النيل، جامعه الفيوم من مصر، الالفي فاونديشن من مصر، مستشفى 57 357، مجدي يعقوب فاونديشن، وزاره الاتصالات المصريه، جامعه بيروت العربيه، الجامعه الامريكيه في بيروت، ونيوكاسل يونيفرستي، وبيود يونيفرستي، وفريس يونيفرستي، وكيل يونيفرستي في المانيا. طبعا 13 فريق من 6 دول في 3 قارات. فيعني كان شغل يعني بصراحه تريمندس. احنا كان معانا 1 مليون يوروز، وزي ما قال الدكتوره رجاء هو البروجكت دلوقتي about to finish، فاضل له شهرين من 3 سنين، وكان في سنه قبله شغل متواصل لكل الاعضاء، معظم الاعضاء دول مع بعض. احنا عملنا دبلوم وعملنا ماستر. فالدبلوم سنه ترمين في مصر، وفي ماستر هيبتدي الاسبوع الجاي بالتزامن مع جامعه بيروت. الاثنين هيبقوا لونشد ان شاء الله. وده كده بكده باذن الله هناخد احنا العلامه الكامله زي ما بنقول. احنا البروجكت بقى لونشد في مصر وفي لبنان ان شاء الله في نفس الوقت. وبعد كده دوسي 60 اي سي تي اس كريدتس، ومعانا كمان 60 اي سي تي اس اخرى في كماستر اوبشنال للي عاوز. المفروض ان احنا عملنا ترجمه للكريدتس دي بالمصري وباللبناني عشان تلاقي السيستم ده. طيب الاستراكشر اوف ذا بروجرام هو في مصر بيطبق يعني 2 سمستر دبلومه زي ما احنا كتبناه بالظبط، وبعدين السمستر الثالث ماستر والسمستر الرابع ثيسز. المفروض ان انت كل ما الطالب يخش ديبر كل ما هياخد حاجات اعمق ويعني متخصصه اكتر. الورك باكجز احنا المفروض دلوقتي قرب نهايه المشروع بشهرين. فالورك باكج نمبر 1 طبعا الاول احنا شفنا ايه هو current situation. احنا بدانا بنبني الدرجه دي. انا بشكر خصوصا يعني البي اي يو والاي يو بي طبعا، يعني tremendous efforts اتعملت مجهود خارق للعادي فوق العادي في المشروع. احنا عملنا current situation في مصر ولبنان. طب الوضع عامل ازاي؟ طيب الاكاديميك والسوشيال نيدز، هل مطلوب البروجرام ده؟ طيب الفارماكوجينوميك اكاديميك بروجرام في المنطقه عامله ازاي؟ هل الاونلاين بروجرامز الاي فورمز موجوده برضو؟ طيب بالنسبه للجاب اناليسيس، لان احنا مش عايزين نشتغل وبعدين نكتشف انه يعني ما كانش مطلوب، ما كانش مهم. عملنا هوسبيتال سيرفي في مصر في 11 محافظه. 95% مش متطبق الفارماكوجينيتكس في مصر. 5% بس من اللي عملنا لهم مسح في مصر هم اللي بيطبقوا الموضوع ده. نفس الكلام تقريبا حصل في ليبانون. عملنا 11 سيرفي على مستشفيات كتيره جدا، 9 تقريبا في بيروت، جريتر بيروت، وواحد في صيدا اظن، ايوه صح صيدا، معملين فقط من 11 اللي بيطبقوا. برضو نفس الكلام، مفيش تطبيق. طب احنا قلنا في اويرنس يا جماعه، انتوا ما بتطبقوش ولا هنا ولا هنا. طب هل انتوا حابين تعرفوا حاجه عن الموضوع ده؟ انتوا حابين تطبقوه؟ عملنا لايكرت سكيل، والحمد لله 3/4 الناس في مصر كانوا عايزين يطبقوه، انترستد جدا. وفي لبنان جينا لقينا نفس الباترن من النتيجه. طبعا ما اكتفيناش بكده في الورك باكج 1، وعملنا دراسه زي ما يقولوا كده كيس ستادي على مستشفى 57 شركاتنا ومجدي يعقوب. هل الكلام ده ايكونوميكالي كويس؟ هل بيفرق في ارواح الناس؟ طب فرق معاكم في صحه الناس؟ كل الكلام ده unpublished، بس احنا كتبناه في الريبورت بتاعنا على اساس ان احنا اتاكدنا فعلا من فعاليه تطبيق الفارماكوجينيتكس على الارض قبل ما نبتدي. طيب احنا كل ده عملناه. طيب يلا بينا نبني كورسات. مش ليها طريقه. اشتغلنا باسس علميه. اول حاجه شفنا الستاندردز، ما احنا عايزين نطبقه في مصر ولبنان. طب ايه هي الستاندردز بتاعت مصر وايه هي الستاندردز بتاعت لبنان؟ طيب عملنا ستاندردز هنا وهنا. طب البنش ماركس، طيب انا شفت الستاندردز، انا مش عايز اعمل برنامج محلي، انا عايز اعمل برنامج على مستوى رفيع. فانا اتاكدت ان ايه انتوا عايزين ايه يا جماعه، وزاره التعليم المصريه واللبنانيه هنمشي هنعمل لكم اللي انتوا عايزينه. بس في نفس الوقت انا ببص على البنش ماركس. البنش ماركس بتاعتي حاجه عالميه، كان اليو سي ال في لندن. بعد ما عملنا كده برضو ما بدأناش في ان احنا ننتج الكورسات، لا احنا قعدنا نفكر ايه هي الكومبيتنسز المطلوبه، اللي هي الجدارات او الكفاءات. يعني ايه هي الاي انتندد ليرنينج اوتكمز. احنا قبل ما نبتدي لا عايزين نفكر، طب الطالب هيتعلم ايه؟ طب ايه هي الكفاءات اللي هيتعلمها او الجدارات اللي هيتعلمها؟ ايه هي الاهداف بتاعت البرنامج؟ وبعدين بدأنا نعمل الكورسات بتاعتنا، عددهم 14 كورس. طيب الورك باكج نمبر 3، انت عرفت ان في جاب اناليسيز مطلوب، الناس عندها او حابه انترستد. طيب وبدات تبني الكورسات بتاعتك، بقى انت عندك معامل تشغل الناس دي. فالخطوه اللي بعدها ان احنا عملنا معامل في 5 جامعات، منهم جامعه النيل زي ما انتم شايفين كده في مصر، جامعه اسكندريه، جامعه بيروت العربيه، جامعة الفيوم، الاي او بي. المعامل دي عشان تبقى اكوموديت الطلبه اللي هيعملوا العملي بتاعهم ان شاء الله. الورك باكج نمبر 4، طيب احنا عايزين نبقى هايبرد، عايزين نخش اونلاين وفيس تو فيس. فاشتغلنا بموديل، طبعا انتجنا كورسات بتاعتنا بقى ده شكلها. يعني الطالب طبعا ظروف ما حدش ضامن كورونا تحصل تاني، بس ظروف الحرب في بيروت، فبقينا عندنا فول سيستم اونلاين. ممكن يبقى جو اونلاين 100% و50 50، ممكن يبقى بلندد باي نسبه احنا عايزينها. احنا عندنا الادوات كلها تحت ايدينا، وممكن نقرر ان احنا نتحرك بلندد باي نسبه حسب الاوضاع اللي موجوده على الارض. مش كده وبس، احنا المهندسين بتوع جامعه النيل عملوا لنا اي لابس. طب الطالب قاعد في البيت نتيجه ظرف حرب او كورونا، طيب في اي لابس زي ما انتم شايفين كده، يعني حاجات بتبقى بسيطة بس بتنفع في الظروف القاهرية. طيب ورك باكج نمبر 5، كان السؤال اللي وزارة التعليم العالي في مصر بتسأله لي دايما، انت عندك الناس اللي يدوروا البرنامج ده؟ اصل انت انوفيتيف، لو انت قمت بيه وفشلت، كان الكلام ده اتقال لي بشكل شخصي، يبقى مصر كلها هتقع وراك. فاللي حصل ان احنا لا، طب يلا بينا بقى ندرب الناس كلهم. خدنا كل المهندسين بتوعنا الاي تي، والمشروع طبعا فيه 100 بني ادم، نص تلتهم مهندسين والتلتين دكاتره. عملنا تدريب على كل حاجه، ايه الكونتنت والفارماكوجينيتكس والمعامل بتبقى ازاي والطلبه بتبقى ازاي. التدريب ده كان في المانيا وفي انجلترا وفي اليونان وفي اسبانيا، وعملنا حتى تدريبات في مصر. وده كان جزء من تدريب المهندسين بتوعنا على الفيرتشوال رياليتي، وازاي بقى تجو اونلاين واي لابس والى اخره. طيب الورك باكج نمبر 6 دي كانت التشالنج الاكبر، يعني ده تشالنج كبير جدا في مصر. خدنا سنه، خلصنا الجامعه موافقه، يلا بقى نروح على وزاره التعليم العالي. دي فيري تاف، صعب جدا.
فبس الحمد لله خدنا الابروفال بتاع وزير التعليم بعد لجنه القطاع. وزير التعليم وافق لنا في 27 سبتمبر 2023، يعني يا دوب بقاله سنه، اقل من سنه يمكن او سنه بالظبط. جامعه اسكندريه دايما واقفه في ظهرنا الحمد لله. البروجكت ضخم مليون يورو، وفي زي ما قلت لكم 13 فريق وست دول في 3 قارات. وجامعه اسكندريه الحمد لله كانت واقفه في ظهرنا، واعتبرت البرنامج ده برنامج مميز. قالت لي اعمل اللي انت عايزه، ده distinguished بروجرام، واطلب المبلغ، اي مبالغ انت عايزها. فصراحه ده يعني شكر كبير ليهم يعني. ورك باكج نمبر 7، وده كان التحدي. بدانا ازاي نعمل امبلمنتيشن. احنا بدانا بالدبلوم في مصر، الماستر الاسبوع الجاي ان شاء الله. طيب الدبلوم بدانا الاول، بدانا حاجه اسمها سيرتيفيكتس، اسبوعين. السيرتيفيكت دي لحد ما عندوش خبر خالص، او طبيب ما عندوش وقت. طب انت ما عندكش وقت تاخد دبلوم، ولا عندك وقت تاخد ماستر، طب خد السيرتيفيكت. فالسيرتيفيكت اسبوعين يخف بيها يعني، يتعرف بيها اكتر على الموضوع ده. وانا استخدمت السيرتيفيكتس دي في كبالونه اختبار. انا عايز اشوف الدنيا فيها ايه، فجربتها 100% اونلاين، وجربتها بلندد، وجربتها فيس تو فيس. انا عايز اعمل ايه، اختبار. ده كان فايدتي انا الشخصيه. فاكتشفت ان فعلا البلندد فورم هو احسن حاجه خالص. بدانا السيرتيفيكت الاولانيه بتاعتنا ان كانسر، الفارماكوجينومكس ان كانسر، والثانيه انهيرتد ديزيز، والثالثه انفكشس ديزيز. وخلى لنا السيرتيفيكتس 3 اساينمنتس و2 تيوتوريالز و7 ليكتشر، وانكلودنج 1 فيزيت لمستشفى 57. طبعا احنا اكتشفنا ان افضل حاجه احنا عملناها فيس تو فيس وبلندد وتوتالي اونلاين. اكتشفنا ان احسن حاجه هي البلندد، انك تاخد ده وده مع بعض. والحلو اللي في الموضوع ان احنا كان جزء من الموضوع اختبار لمدى ان الناس حابه كورسات. طب الكورسات مبنيه كويس، طيب الناس عندها اويرنس بالموضوع بتقدم عليه. جينا بعد كده، بعد ما ظبطنا الدنيا بقى في السيرتيفيكتس وخلصنا بالونات الاختبار، دخلنا في الفول دبلومه في مصر. فقلنا لا، بلندد ليرنينج هو ده، ذيس ذا واي. ف 50% المفاجأة الحلوة إن تقدم لنا 1370 ابليكنت في مصر، وده رقم خارق للعادة. هو دكتور قنصوة رئيس جامعة اسكندرية ما سألني، أنا قلت له 1370، الراجل يعني اتاخد شوية، رقم مهول. فده معناه إن السيرتيفيكت سمعت وجابت سمعة كويسة. وغير طبعا إن الواضح إن في إقبال الحمد لله في مصر. خلصنا طبعا مش هنقدر اكوموديت 1370 طالب، فخدنا 55 طالب بس. برضو عايزين نجرب فيهم السيستم، ما هو برضو اول دفعه دي احنا بنطمن تماما ان كل حاجه ماشيه كويس جدا. فخدنا التوب 55 ابليكنتس فقط. وبرضو دبلوما ان اكشن من 4 نوفمبر اللي فات، فيس تو فيس كتير. خدنا ترم اول وترم تاني. كان في تيتشنج ميثود ليكتشر وبراكتيكال سيشنز ريكوردد، وفي حاجات لايف، وفي فيزيكال لابس، وفي اي لابس، وفي تيوتوريالز، في كل حاجه. فطبعا ده الفيس تو فيس في جامعه اسكندريه. دكتور سعيد كان معانا في الدبلوم ده اونلاين. وفي معامل برضو فيزيكال لابس في الكامبس بتاع اسكندريه. واستخدمنا الكمبيوتر لابس في السيميوليشنز، والاي لابس كانت برضو عملت شغل كويس جدا. وبعدين طعمنا الترم الاولاني والترم الثاني بزيارات ميدانيه لمستشفى 57. الناس درسوا وفي نفس الوقت راحوا شافوا بعينيهم ازاي بنطبقوا على المرضى. وعملنا كورس ايفالويشن. بعد كده جت المومنت اوف تروث، عملنا بقى وزعنا السيرفيز. يا جماعه شوفوا احنا كويسين، انتوا الكورسات اتبسطتوا منها، استفدتوا منها الحمد لله. زي ما انتم شايفين الازرق هو نسبه الاجرين، اهميه الكورسات وكفاءتها والى اخره. طبعا ان احنا نجيب 70% نسبه دي 90%. الكورسز ار امبورتنت. لما ناخد ما بين 70 ل 90%، اراوند 80% نسبه رضا. انا كراجل اكاديمي في المجال ده، انا شايف ان ده من اول راوند ده كويس جدا. احنا بنطور طبعا زي ما انتم شايفين، نسبه الرضا عاليه جدا الحمد لله. طلعنا نسبه النجاح كانت قرب ال 100%، ان احنا برضو صفينا وخدنا اكفأ ناس. كان كل ال 55 تقريبا الجي بي اي بتاعهم فوق. فكان ما شاء الله عليهم يعني. هم برضو كان بيتحسب لهم دايما ان اللي بنى الكورسات دي الانجليز والالمان والاسبان واليونان، فهم بنوها ماليش دعوه، انا هبني كورس انا هبنيه زي ما هو في بلدي. فهو اتبنت فيري اب تو ديت، ما رغم ان احنا في مصر زي الفل وكويسين جدا، برضو في فروقات ما بين الطلبه بتوعنا. فهو الفرق ده هم تجاوزوه يعني بصعوبه، والناس تعبت. بس انت عايز تدرس زي ما بيدرسوا في المانيا، زي ما بيدرسوا في بريطانيا، فمعلش لازم تتعب معايا. كانت نسبه النجاح 100% الحمد لله. ودول الطلبة بتوعنا الحلوين اللي نجحوا في الدبلومة بتاعتنا. انتخبنا منهم في اسكندرية 13 طالب الحمد لله هيكملوا معانا بدأ من الأسبوع الجاي الماستر. دول بقى صفوة الصفوة، دول ال 13 من ال 55، دول بقى الكريم دول كريم، وربنا يسهل والدنيا نكمل معاهم بإذن الله في اسكندرية. وفي بيروت هنا أعتقد إن هو خدوا برضو 4. فإن شاء الله خير يعني. طبعا في نهاية البروجكت بنينا درجة كما ينبغي. كنا لازم الورك باكج نمبر 8 نكمل في ازاي البناء بتاعنا كان بيتم، ان احنا ما كناش بنشتغل بشكل عشوائي. احنا واخدين مليون يورو، المفوضية الأوروبية دايما على راسنا، بتراقبنا، بتتأكد ان كل سنت راح في مكانه، كل حاجة اتعملت مظبوط. يعني مفيش مكان او مساحه ميسنج يعني. فعملنا بنعمل كيك اوف ميتنج، بنجتمع كل 6 شهور في بلد من الست بلاد الاعضاء، بنجتمع كل 3 شهور، بنعمل فاينانشال ريبورت دقيق جدا. انا شخصيا اللي بكلم المفوضيه الاوروبيه، انا المخول الوحيد ان انا اكلمهم حسب اللائحه. معيننا اكسترنال اكسبرت، وده ملوش دعوه بالبروجكت، وده بيراقبنا، وده عين المفوضيه علينا. المفروض الاكسترنال بروجكت ده كان عنده بروجكت شبهه قبل كده، وهو المفروض ان هو شبه مستقل وكان بيراقب تقدمنا. كنا بنشتغل برضو في الديسيمينيشن، ان احنا دايما، والايفنت النهارده واحد من الديسيمينيشن ايفنتس بتاعتنا، ودي نهايه اخر ديسيمينيشن خالص في المشروع. احنا بقالنا 3 سنتين بنشتغل في القصص دي. عندنا الويب سايت بتاعنا، عندنا الفيسبوك بيج بتاعتنا، واللينكد ان اكونت بتاعنا. طبعا بروجكت مانجمنت 36 شهر، بنتقابل دايما كل 6 شهور فيس تو فيس، اتليست كل 6 شهور. وده كان الميتنج في جامعة النيل، أول ميتنج خالص، وده كان في جامعة أوبيدو في أسبانيا، وده في بيروت، وده في كيل في ألمانيا، وكان في واحد في نيوكاسل للأسف نسيت أحط الصور بتاعته. فطبعا الغرض يعني كنت عايز اقول ان البناء بتاع البروجكت كان بيتم بطريقه علميه ومش عشوائيه اطلاقا يعني. اخيرا وليس اخرا، انا في 100 واحد اشتغل في البروجكت اتليست على البيرول بتاع البروجكت، 100 واحد او اكتر. بس دول النجوم الكبار اللي اشتغلوا معانا. وطبعا انا اسف لو في حد صعب بالسهو يعني. دي البارتنرز المصريين طبعا. مصر طبعا عدد ضخم، نص 40% من اللي شغالين في البروجكت كانوا من مصر. وانا معتز جدا بالبارتنرز بتوعي اللي من خارج مصر. دكتور سعيد البطل بتاع البي يو، دكتورة ناتالي البطلة بتاعت الاي او بي، ومعانا من انجلترا دالي وفانجيليس مانوبولوس من اليونان، ولويس من اسبانيا، وانجولف كاسكوربي كان رئيس الايوفار العالمي من المانيا. وشكرا لحضراتكم جدا، اشكركم على الاستماع.
يعطيك العافية دكتور أحمد.
خلاص. جود افترنون. اول حاجه انا بشكركم جميعا للحضور. اكيد بشكر دكتوره رجاء، وعلى التنظيم دكتور سعيد، بشكر دكتور احمد طبعا اكيد، وبشكر دكتور عبد الله. يعني هو اداني فرصه ان انا اشارك في حاجه زي كده في البروجكت، وبشكر كل الحضور. والحمد لله يعني ان شاء الله كليه الصيدله الماستر خلاص احنا ابتدينا، يعني بقى لنا 2 ويكس ابتدينا في البارت الاول من البروسيس، وان شاء الله باذن الله هنكفي باذن الله. Now it's my pleasure to introduce today's session entitled Integrating Pharmacogenomics in Middle Eastern Healthcare, Current Insight, Challenges, and Strategic Directions. This critical topic presented by Dr. Saeed Shamiya, Associate Professor of Human Genetics at Beirut Arab University, Faculty of Health Science. He completed a PhD at University of Deloran, and he postdoctorate fellowship at Institut de la Vision, Sorbonne University, where he worked on applying next-generation sequencing to identify novel genes causing several forms of inherited retinal diseases, IRDS, which led to the identification of Kizona gene. His research identified novel genotype and phenotype association with IRDS and pharmacogenomics. He has published over 65 articles and contributed to developing a patent W0. He is also serves on editorial boards of several journals and received several international and national grants. Dr. Saeed will explore the following role of pharmacogenomics in shaping healthcare in our region. Dr. Shamiya will shed light on current advancement, obstacles, and the strategic pathway needed to incorporate pharmacogenomics in the healthcare system in Lebanon. I look forward to stimulating a discussion on how we can advance these essential aspects to our in Lebanon, inshallah. Shukran.
Thank you, everyone. Thank you, Professor Azza, for introducing me. We are very honored also to have you. Professor Azza will be responsible for the master's program. Thank you again. The students are lucky to have you. Thank you, Doctor. So in my presentation today, I will be showing a recent work that we have done in collaboration. It's a work that we have done in collaboration between 3 universities, between BAU, our university, Qatar University, and Al Faisal University. We wanted to start some sort of collaboration that deals with the familiarity to pharmacogenomics, especially current insights, challenges, and strategic direction. So this work, as you will see, it was done between 3 countries. So I always like to start my presentation with this slide, and this slide about genotype-phenotype associations. After all, a phenotype for us geneticists, a drug for us geneticists is no more than phenotype that can be quantitative, qualitative, and it can have also all its parameters. So studying the relation between genotype, phenotype is not something new. The first one who studied that, at least reported this study between genotype and phenotype, was Pythagoras 2,500 years ago. They were studying the effect that had fava beans on, yes, I think, yes. Yes. So thank you. So the first one was Pythagoras, who studied mainly the effect that the fava beans had on the people's blood. And at that time, it was thought that fava beans contained evil spirits. That's why some people, they take fava beans and they become disease. Nowadays, we know that this is no more than favism and hemolytic anemia. Also, the relation between genotype and phenotype was also studied by Gallen 500 years later, who said explicitly that no external cause is efficient without a predisposition of the body itself. Otherwise, external cause which affect one would affect all. And that's what we had with COVID-19 and the difference in response that we had with COVID-19 lately and the infections. So this has evolved to become in a part, not all the part, the modern pharmacogenetics, because we said that a drug is, for us and many, is no more than a phenotype. So 2000 years later, this field has significantly evolved to become pharmacogenetics, where every person has to receive the right drug at the right time and the right dose. And pharmacogenetics has enormously benefited from the sequencing of the human genome that allowed the transformation of pharmacogenetics into pharmacogenomics and did all this important shift between pharmacogenetics and pharmacogenomics. So as I have said now, pharmacogenetics integrate genomic, environmental, and lifestyle information to inform medical management decision. However, several challenges interferes with its routine implementation, including, for example, we know current clinical practice, knowledge gaps, lack of interest among healthcare professionals, technological hurdles, and cost-effectiveness side. And to be honest, we were interested in studying those aspects between the three countries that are really different at many levels. So if we take, for example, Lebanon, we know that Lebanon, for example, has several pharmacogenetics laboratory has been established in the last decade, and one of them is the lab of Professor Nathalie Zreib in BAU, also in AUB, I'm sorry. And many studies have employed NGS and also other genotyping techniques to demonstrate and to show active participation in the field. So there was the pharmacogenomics labs and also many studies about genotype and drug associations. PGX education is also included in the curricula of Lebanese higher education institution like the curricula of the Faculty of Pharmacy at BAU. However, the clinical implementation remains challenging. Specifically, there is still a need for further education effort to improve foundational knowledge and capitalize on significant opportunities for advancement. If we go to Qatar, for example, we notice considerable studies have been published on PGX. These studies were supported by an advanced healthcare system, infrastructure, the national also Qatari Genome Project, and numerous educational initiatives focused on precision medicine. Qatar also has undertaken numerous educational initiatives like courses for healthcare providers directly and indirectly being implicated in pharmacogenomics. Also, our studies, our literature review showed that the physician and pharmacists in Qatar, they possess positive attitudes and are motivated to get engaged in clinical application and patient education. If we go to Saudi Arabia, the third country where we also perform the study, we can notice that in Saudi Arabia, PGX is an emerging field with significant implication for precision medicine. However, there is some sort of lack of knowledge, and you will be seeing it in understanding PGX among healthcare professionals, including, most importantly, clinicians and pharmacists. So there are yet no comparative study to investigate pharmacogenetics, familiarity, implementation, associated challenges across Qatar, Saudi Arabia, and Lebanon, and that's what you will be seeing. So to assess this research gap, we have started classically by taking an IRB approval from the three universities, Qatar, Al Faisal, and BAU. all participants, they took and they signed informed consent, and they were informed that all the data will be anonymous without any names, and everything will be confidential upon completing the survey. Mainly, our target population were three categories: healthcare professionals, not only pharmacists, also, but other healthcare professionals indirectly also implicated in pharmacogenomics. We sent the survey also for academics and for clinicians. 18 questions were asked to the participants and about the implementation practices, obstacles, and potential strategies and future education needs. So mainly, our participants were recruited through purposive sampling, targeting, as I said, professionals directly or indirectly implicated in PGX, like me, for example. I'm indirectly implicated in PGX. So, and as mainly we were conducting some descriptive study. In terms of statistics, we have only used the chi-square independence test. So we have sent this survey to more than 1,000 individuals across the three countries. Around 337 people, they answered us. If you see a bit the numbers, 1/3 of them was from Lebanon, the other third was from Qatar. Saudi Arabians were less responsive to our survey. So with 55 of 337 people, 80% of the participants were having less than 45 years old. The gender distribution were approximately the same, with more females answering and being interested in pharmacogenetics than males. I don't know if pharmacogenomics is a woman word, it seems. Men are less interested about pharmacogenomics. In Saudi Arabia, it was 50-50. It was equality. Some part, as you see, around 25% of the participants were from academia. The majority in Lebanon and Qatar were healthcare professionals, and most importantly, pharmacists. In Saudi Arabia, the majority were academicians, with also 15% and 15% clinicians and healthcare professionals. Professional experience varied, but Qatar and Saudi Arabia showed the higher representation in the more experienced category. So people from Lebanon, they were motivated to answer us, but they were having less experience and they were younger than the Saudi and the Qatari respondents. So when we asked them, do you believe that pharmacogenomics has the potential to significantly improve patient outcomes in clinical practice? Everyone, without any significant difference, all of the people, 94% from Saudi Arabia, 86% from Lebanon and Qatar, they said yes, without any hesitation. And in terms of interest, as you can see, around 98 to 95% of the people, they were interested at different degrees. Slightly interested, and very interested. But if we look on the very interested, for example, in Lebanon, 37% were very interested. Also in Qatar, the same thing. In Saudi Arabia, they were a bit more interested in terms of learning about pharmacogenomics. When we asked them, since you want to learn about pharmacogenomics, what topic would you like to learn? Lebanese respondents, the majority of them, they said, we are interested in learning about cancer, chemotherapy, pharmacogenetics. Qatari respondents, they said the two major answers were cardiovascular and diabetes in Qatar. It's a different, also complex diseases, but a different category. In Saudi Arabia, cancer, complex diseases in general, and cardiovascular were the top three interests. And it shows a bit the mortality and morbidity rate. It reflects the morbidity rate and mortality seen in those countries. Lebanon, it's more cancer. We know the higher incidence of cancer. Arab countries like Qatar, more obesity, diabetes, cardiovascular, and Saudi Arabia, cardiovascular and cancer, both complex diseases. So next, we split the people according to their profession into academics, clinician, and healthcare. And when we ask them, do you believe that pharmacogenomics can improve patient outcome in clinical practice? Yes, all of them said yes. Clinician, academics, and healthcare how much are you interested? Also, if you look, academics showed the high interest. For example, 50% of the academicians in Lebanon, mainly, not in the Lebanon, I'm sorry, 50% of people working in academia, they are highly interested. Clinicians were interested, but not highly. Some clinicians, like ophthalmologists, I have asked them, they know nothing about pharmacogenetics, nothing at all, ophthalmologists, for example, nothing. And also, if you go to healthcare professional and pharmacists, yes, pharmacists and healthcare, you have around 75% of the healthcare professionals, yes, they are either interested or very interested. When we also split the interest in terms of academic, clinician, and healthcare, so in all participants, it's not country-based. So you can see that academic people in academia, they are either maybe for research purposes, they are interested in all the complex diseases or for cancer therapy. However, clinicians and healthcare, both of them, they are interested the most in cancer and cardiovascular, maybe because they see them, they work with those categories. Academicians, they went more into either a general aspects of complex disease or cancer chemotherapy. So in terms of familiarity, as you can see, all of them are familiar. 87% around, they are familiar with PGX from all countries. Once we ask them, have you attended any pharmacogenetics educational talk or during the last 2 years, the majority, especially Lebanon and Qatar, they have not attended any. Yes, the majority of them. However, people in Saudi Arabia, they, especially academic people, they attended some pharmacogenetics talks. Once we ask them if they have integrated PGX testing into the clinical or into research, we see that, yes, routine, in terms of routine, only less than 5% of them, they did it. However, the majority of people, they have never done it. However, they show positive attitudes toward using it in research for masters, for example, for postgraduate, or for clinicians to apply it in clinics. The last part that we assessed with those participants is the overall challenges. So what do they believe, which factors are the top challenges in the 3 countries? So despite the differences in economies and the wealth, you can see that the #1 challenge for pharmacogenomic testing is the test cost and the reimbursement. The second one is the insufficiency of physician knowledge and awareness. And the third one is the unavailability of test technology or infrastructure/manpower. Once we split per country, also, as you can see, the 3 top challenges remain top challenges in the country. Okay, the differences change. However, for example, for Saudi Arabia, for Qatar, and for Lebanon, the #1 challenge is the test cost and the reimbursement. Okay, here it's 5%, but all the other challenges, they have less proportion. So regardless the economical status, the #1 challenge is the test cost and reimbursement. So if we're gonna discuss a bit our findings, we have noticed a higher familiarity and educational involvement with PGX in Qatar and Saudi Arabia compared to Lebanon. Significant differences also were noted in the topics, particularly regarding diabetes mellitus, for example, in Qatar, and cancer in Saudi Arabia and Lebanon also. But despite those differences, similar trends of challenges, they were encountered in the 3 countries: test cost and reimbursement, unavailability of infrastructure, manpower, and lack of funding and investment support. And the Erasmus Plus is a big plus to this gap of lack of funding or support. The recommendations, if we want to do recommendation, we have to do educational and implementation strategies, but they should be tailored to each country needs and barrier. In Qatar, the efforts should, for example, focus on transitioning from occasional or routine PGX integration to a more comprehensive standardized approach. Specific attention, as I've said, should be given to diabetes in Qatar, diabetes mellitus for sure, and cancer chemotherapy in Saudi Arabia. Addressing economic factors and raising awareness about PGX potential benefits could encourage adoption in Lebanon and other countries. Collaboration with stakeholders, including healthcare professionals, educators, policymakers, and patients also is essential. Engaging primary care physicians and pharmacists also can enhance the knowledge and experience with pharmacogenetics testing and facilitate its integration into clinical routine. By this slide, I end my presentation and I thank you for your listening. Thank you. اتفضلي دكتور.
التشالنج الاساسي اللي هو الكوست.
Cost, صح. Cost of and reimbursement, yes. لا.
يعني عن مسؤوليتي ان هو الكوست هو السبب. فانا بقول بالنسبه للبنان يعني في لبنان اوكي كبرسنت طبعا، بس انا مستغربه ان البرسنت دي في قطر
صح.
السعوديه
ايوه صح.
احسن كمان في اللابوراتوري فاسيلتيز.
And for them, it's still a major challenge. For them, the cost, they don't want to afford it on personal basis. As you know, it's not yet taken into consideration by insurance companies. They feel it is expensive to be paid by someone's own pocket. Maybe because they are not aware of the importance of such tests. Also, they are finding such some proportionally higher or yes or expensive. But to be honest, yes, this is what we have seen in the three countries. Yes. But in Lebanon, it was, as a doctor, it showed higher percentage of people. More people said, okay, test the reimbursement. In other countries, the partition was a bit different. But still, if we compare test reimbursement, how many people said test reimbursement to other? Yes, it was also different.
بالنسبه كمان للبوليسيز يعني برضه انا شايفه ان المفروض ان الدول اللي هي زي قطر والسعوديه يكونوا بالنسبه لهم سات البوليسيز عشان عمليه الكولكشن اوف جين بات او الحاجات دي اسهل من ليبرال.
طبعا
برضه انا شايفه
yes
عندهم
challenges especially when they started the genome, for example, the genome project, which is half the way. If you know the variation, it's half the way. But still, this is what we have seen. But أكيد they are, in terms of reaching their goals, they have done more significant steps than us. Hopefully, we can reach them. Thank you, Doctor. Thank you for the questions. Right. I think now we can have the coffee break because because it was after Muna. After Muna. Okay, sorry. I have marked. Thank you, Doctor. Yes, Doctor. Yes, Doctor. No worries, Doctor. Thank you. So Miss Muna Salim couldn't make it and come with us today. So she sent me her video, and I will be showing her video. So yes, no, yeah. بس بدي Right. So now I will be showing the video that Mrs. Munam Salim sent us. Mrs. Munam Salim is the Director of Development and Scholarship at Alfi Foundation for Human and Social Development. She has sent us a beautiful video that I would like to share with all the attendees about the progress of our project. I hope you like it.
So I am police from UK research chance to visit Egypt and to contribute to the progress on the continent and the quality of the teaching of the scholar, the total process. So at the end, I am really excited and want to say impressed. See what has been so this.
Thank you. We will be having a coffee break, and then after there will be the talk of Professor Zreib from AUB. Thank you and see you soon.
So is that after half an hour?
Yes, 30 minutes. Yes, thank you. بس خليها بهنا
مش لاقي لك الا
بلا لا لا مش عاملين
Hi, Saeed. Natalie معك. Can you hear me? أنت muted. I cannot hear you.
I'm hearing you very well. نحن وهون we're hearing you perfectly. يلا رح نحط المايك. Yes.
Can you hear me?
ايه great we hear you. بس ايه شوي. Okay. Please give it try, Natalie.
Hello, everyone. Can you hear me?
Yes, we can. بس مش واضح.
بس ليه مش طالع من هونين؟ ليه المايك؟ هلا فيني انا المايك داير. يلا هلا بيمشي. بس ليه مش عم يطلع الصوت من هون؟
أنا عايز يطلع حدا.
الزوم بيطلع من اللابتوب.
نقلب مايكروفون على
هيدا بيعمل صوت. هيدا. En fait ناتالي هو الصوت مش كتير عالي لأنه من الزوم طالع من الكمبيوتر. that's why.
هلا عم تسمعوني؟ يعني ما في يصرخ أكتر من هيك.
لا
بدك تعرف على السبيكر اذا بحط
وين السبيكر؟ طيب I think it should be fine. طيب دكتور عز
أنا بس رح أوقف
هلا كثير منيح.
الكاميرا.
هلا we hear you very well ناتالي. we hear you very well.
All right.
We are welcome you to this session on what is the landscape of pharmacogenomics experience in Lebanon. Today, we are fortunate to have with us Professor Natalie Zoghib. Dr. Natalie Zoghib is a professor at the Department of Pharmacology and Toxicology at the American University of Beirut, Faculty of Medicine. She is a family doctor who graduated from AUB and later specialized in pharmacogenetics, drug metabolism, and the individual differences in drug responses at University of Petersburg. In 2007, Dr. Zoghib set up the Pharmacogenomic Laboratory at AUB. Her current work focuses on studying how genetic differences affect the way people process medication, especially in treating cancer like breast cancer and childhood leukemia. Initially, Dr. Zoghib used a candidate gene approach to identify genes and might impact drug responses. But she has recently shifted to more advanced techniques that allow for analyzing large number of genes and studying more diverse population. She is also developing a research registers to follow patients over time. Her research aims to better understand and unique challenges and opportunities of applying pharmacogenomics in clinical practice in Middle East and North Africa. Dr. Zoghib works is supported by various grants. In 2020, he has honored the Abdurrahman Shuman Award, Arab Researcher in Pharmacogenomics. Today, discussion will be explore how Lebanon is progressing in this field and what is the mean for future personalized medicine. Let's go start. Thank you.
Thank you for the introduction. I hope you can hear me. Apologies that I did not come to the meeting today. No need to explain. God bless Lebanon. Allah يحمينا كلنا. Just in case I disappear, بتكون الكهرباء انقطعت. Bear with me in 1 minute. I'll be back. All right, so let's get started. The pharmacogenomics, the Lebanese experience. We have just recently in 2024 actually published an article on this, and Saeed is aware of this manuscript. Pharmacogenomics in Lebanon, current status, challenges, and opportunities in the Pharmacogenomics Journal. Here we really talk about the research landscape in Lebanon, and we also talk about the clinical landscape and what can we do and what should be done. In that manuscript, you see this figure, if you access it. And here we show what are the researches that we have in Lebanon in pharmacogenomics. We have a lot on cancer. We have also some on neuropsychiatry, such as opioids and SSRI. We have obviously cardiovascular, warfarin, clopidogrel. We have type 2 diabetes, and those are the manuscripts actually published from BAU by Saeed Shakhsiyan. And it's interesting that in addition to studies similar to others, we have also some that are peculiar to us. For instance, we have some toxicology or toxicogenetic study. For instance, bladder cancer and NAP2 polymorphism, bladder cancer and GST enzymes. Those are things that are peculiar to us. We also have some nutrigenetics, and also you will see frequency studies. Yani you have a study looking at the frequency of a certain genetic polymorphism. And those are still important in our area of the world because we are different. Our frequency is not necessarily like the Western world, and this is something that we have to do. So if you're really interested in the full landscape, I highly recommend that you go to this article. But I cannot talk about all of that in 20 minutes. So what I will do, I will focus on the research that we have been doing since 2007 at AUB. I will not talk about everything, but I will use breast cancer as a case study and show you how we moved from the candidate approach all the way to next generation sequencing and what are the challenges and the opportunities. I will talk a little bit about a cardiology example and ALL, and I will talk a lot about some surveys that we have developed. If you're interested to know more about the lab, there is also an article about us in Pharmacogenomics in 2017. So again, what I will do, I will talk about breast cancer, and this is a case study if you want to illustrate the case in Lebanon, then a little bit about challenges and how we can move forward. So let's get started. So this is a case. This is not real. It didn't happen. I just created from my head. So we have Mrs. Breast Cancer and her neighbor. Those are two ladies. They are 50-year-old. They present with a breast lump. We do a biopsy. It turned out to be high-grade intraductal carcinoma. Estrogen receptor progesterone positive, HER2 negative. We do surgery, modified radical mastectomy, and lymph node dissection. They have exactly the same stage. They receive exactly the same combination therapy, 5-FU, epirubicin, cyclophosphamide, and tamoxifen because they are estrogen receptor positive. So very similar, same presentations, same treatment. However, response is really different. Mrs. Breast Cancer, she gets so many adverse events: nausea, vomiting, febrile neutropenia. She needs whole blood transfusion. However, on the bright side, she is in complete remission. However, her neighbor, which is also exactly the same, for some reason, she responds differently. She has no adverse drug events at all. However, she did recur and she did pass away 1 year later. So what am I trying to say here? What I'm trying to say is this term that was introduced earlier today, inter-individual variability. Those two ladies, Mrs. Breast Cancer and her neighbor, are different. They are variable. And there are a lot of factors that lead to this inter-individual variability. It could be sex, age, race, but in this case, they are the same. Could be BMI, liver and renal disease, drug-drug interaction, but the focus today is on pharmacogenomics or genetic polymorphisms. So this is a case scenario that can happen every day. How did we address that as a research in AUB? We said, okay, so we want to do a pharmacogenomic study in breast cancer, see what happened. And we could do targets in disposition, elimination, or in response, right? But we cannot do everything. So we decided to start with disposition, specifically drug metabolizing enzymes and specifically CYP enzymes. So we tabulated the drugs that are typically received in patients with breast cancers. In this table, you see breast cancer and non-Hodgkin lymphoma because we were at the time interested in both diseases. But let's focus on breast cancer. We said, okay, those are drugs that breast cancer patients receive. Which one are we going to focus on, knowing that patients receive combination therapy? Remember, those two people took FEC, F-E-C. Well, we said maybe 5-cyclophosphamide is a good start. Why? Because you have the CYP2B6 here. You see, it's unique. You don't see it anywhere else. You see it actually here with tamoxifen, but tamoxifen is not given in combination, so it's okay. So we said, let's start with cyclophosphamide. And as a matter of fact, this is a very simplified pathway showing how cyclophosphamide is activated into neurotoxic compounds and this phosphoramide master that is important because of its anti-cancer effect and of course its hematologic toxicity. So we decided we're going to focus on breast cancer. We decided we're going to focus on cyclophosphamide. We decided we're going to focus on CYP2B6. What's the next question? The next question is, which variants do we do? And of course, there are many variants. At the time, we did an extensive literature search, and we said we're going to focus on those 3 CYP2B6 variants. Now, to make the story short, what did we find? So in here, I show you data on toxicity, WBC being the white blood cell count, and ANC being the absolute neutrophil count. And here, for example, we have patients who receive 4 cycles of chemotherapy. Obviously, you start with a certain number and it decreases over time. This, of course, will happen. But what you see here, some significant results, the black line on top of this gray line, the variants had less toxicity. And that reminds you of who? That reminds you of Mrs. Neighbor. And as a matter of fact, those variants, when you look at survival here, the variants here are this black line. As a matter of fact, okay, less toxicity, but worse survival. So yes, we published that CYP2B6 variants lead to this effect. But now you tell me, so what? Okay, we're very happy, we published, we're excited, but this is limited. We started with a small sample size, about 200 people, combination chemotherapy. Of course, we tried to focus on cyclophosphamide. However, our patients do receive a combination chemotherapy. This is retrospective chart review, so we could not put everything. And as always, limited funding. We did 1 gene and only 3 SNPs, right? And what we actually did is this candidate SNP approach. So we did our literature search and we did 3 SNPs. But if you look now at the DB-SNP database, you find that currently there are 12,589 CYP2B6 variants, and we did only 3. So, okay, we're happy, but we still have to do a lot. And if there is only one word I would like you to remember from my talk tonight, it is collaborations. Collaborations are key. We cannot do this alone. If we want to do more, if we want to do larger sample sizes, if we want to do next generation sequencing, more funding, whatever, we have to collaborate. And we knew that ahead of time, and we actually did collaborate. And I'm showing you here the case study of tamoxifen. We're still in breast cancer, and tamoxifen is the hormonal therapy, the SERM. And this is a simplified pathway showing that tamoxifen is activated by CYP2D6 into endoxifen, which is the active metabolite. And if we were to do the candidate approach, like we did with CYP2B6, we could have done those. Those are the common ones, in addition to CYP2D6.41, which is common. But we didn't. We wanted to do more. We collaborated with colleagues from Germany who had access to the Affymetrix assay. And in here, you can do tons of CYP2D6 genotypes, and then you can categorize your patients into several phenotypes, being ultra metabolizers, extensive, intermediate, or poor metabolizer. And also they had PCR to do the copy number. So we did that, we collaborated, we increased our sample size. We had 3 cohorts, We had 3 cohorts, us, Singapore, and the UK. And you see, if you want to look at this one here. So we measured tamoxifen and endoxifen in plasma. And you can see that poor metabolizers had a higher ratio, meaning that the CYP2D6 was not active to lead to endoxifen, whereas the ultra metabolizers had a low ratio. And so what? Does this affect any outcome? Yes, it did. And this is a survival curve for our data after 12 years of follow-up, showing that, as a matter of fact, this dark line here, those poor metabolizers who do not activate tamoxifen into endoxifen, unfortunately, do not do well. They die before those who are ultra-metabolizers. They do not respond to tamoxifen. Fine, so we're happy. What have we done so far? We started with 1 gene, 3 SNPs. Now, 1 gene, CYP2D6, a lot of SNPs. But this is a simplified pathway. If I show you the actual pathway from the PharmGKB, look at that. So we only did CYP2D6. We could have done many other CYPs. We could have done phase 2 enzymes. We could have done even transporters. So even this is not enough. So what I'm trying to say is that you should do beyond the CYP enzymes. And again, we were aware of that. And here I'm showing you the case study with taxanes. Again, I'm showing you little things here and there. And we had access to the DMET plus array, and that is the drug metabolizing enzymes and transporters. So we had several drug metabolizing enzymes with several transporters. And we did that with taxanes. And to make the story short, so every single point in this Manhattan plot is a variant in a certain gene, in a certain chromosome, and we did discover a few things. So again, we are happy. We are moving beyond the candidate approach. But is that it? Of course not. We need more, and now much more is being done. And now actually the arrays are becoming no more a la mode. What is a la mode now is next generation sequencing. So we need to do more. At least for GWAS, we did. So in continuation with our colleagues in Germany, we did the CYP2D6, the tamoxifen study using GWAS, and those are the 3 cohorts, again, Singapore, Germany, and UK. And we found, in addition to that gene here, CYP2D6, we found others. And now, as we speak, we are actually writing another manuscript using next generation sequencing. So what have I done so far? I showed you this small case study on breast cancer, showing you how in research, you start with a candidate approach, but we need more extensive genotyping. Fine. But another question is, how about practice? And again, all of that is discussed in the manuscript that I showed you at the very beginning. Clinical utility. This is a very important term in pharmacogenomics. Is this useful? Are those publications only to be promoted and be happy about it and stay at the university? Is this being useful? Are we making any difference in our country? And this is the ACCE wheel that I really love. It's from the CDC. A is for analytical validity, C for clinical validity, the other C is for clinical utility, and E is for ethics. What is this about? Well, I think that my lab, and I'm sure many other labs in Lebanon and Egypt, they're doing very well in analytical validity, meaning that if you say from your lab that this patient has this polymorphism, we can trust you, we can believe you. The assay is good, the sensitivity is good, the specificity is good. Of course, the studies that I showed you so far are clinical validity. Retrospective chart review, we prove that whatever others have done is also applicable to us. Of course, we use informed consent, we use the IRB and all of that. But does this really affect the outcome? And for me, this is the major challenge now in our area of the world. Okay, we have those studies in the review that I showed you, but is this being practiced? And here, let me talk about 2 examples at AUB. So this table is showing some actionable pharmacogenes. What do I mean by actionable pharmacogenes? Meaning that some genes where you have to genotype for some variants in relation to some drugs. So there are guidelines, for example, if you want to start clopidogrel, you want to genotype for some CYP2C19 polymorphism, star 2, star 3, before you start it to make sure you don't have bleeding or that you have a good response, SSRIs, etc. So those are well established. How about in Lebanon, what happened with us at AUB? And let me give you those 2 examples. First, with CYP2C9, warfarin, and acenocumarol. And that example was mentioned by Ahmed Wahid earlier today. So those are oral anticoagulants, very commonly used. In Lebanon, we have acenocumarone. Well, we did the study in 2012, some time ago, and we showed that, yes, as a matter of fact, CYP2C9, star 2 and star 3 are important in the Lebanese. If we have those polymorphism, you have to start with a smaller weekly dose, and the same applies to VQRC1. Fine, so this is clinically valid. And we went beyond. We said, you know what? We want our doctors to use that, to use this data. So we developed a calculator. And if you go on this website on AUB, this calculator exists for our Lebanese population. You can go and you can plug in the age, the sex, the INR, the target INR, the CYP2C9 genetic data, and the VQRC1 genetic data. And the calculator will tell you what is the best dose that you should give to your patient to have the least toxicity. But do you know what? It didn't work at AUB. So we launched this calculator, we brought the test, we did everything we needed. They simply did not use it. Why? One, they're not ready. They need more education. Two, the genetic test is not covered by the companies. Three, it takes time to do the genetic test. So there's a lot that needs to be done before saying, okay, this is the test, it's available, do it. And we unfortunately failed. But now, after several years, I think soon we are readier because there is a little bit more data on that, and we know how to do it, as I will show you in a few slides from now. The second example is TPMT. So this is with children of childhood leukemia. They receive a lot of treatments for several years, but one of the drugs is 6-mercaptopurine. And this drug is metabolized by an enzyme called TPMT. And if we have those polymorphisms, we have no enzyme activity, and hence 6MP is not deactivated, and it leads to severe myelosuppression with febrile neutropenia and risk of death. This is why people who are homozygous for those polymorphisms, you absolutely have to decrease the dose by 90%. So this is super important, and childhood leukemia is prevalent, and those are kids. And at least this is a small success story. At AUBMC, we actually do genotype for TPMT, and we published this data in 2016. Remember, it's an uncommon polymorphism. We found 3 out of about 137 people, and those 3 people actually had major toxicity. But also we went beyond. We looked at more candidate variants such as ITPA and NOD15. For instance, NOD15 is a very rare polymorphism. Look, we only had 1, but if a patient had that polymorphism, oh my God, you have to decrease the dose excessively. And this is a very common polymorphism in Asian, not in us. But you're going to tell me, okay, Natalie, bravo, you published all of that, but so far you have been doing what others have done. True. We have been applying the candidate approach, but we are different, right? Maybe we have genetic polymorphisms that are common in the Lebanese and the Egyptians and not in the Western. Just like the Asians had their NOD15 polymorphism that is super important. So just like the Asians have the HLA polymorphism that are very important for hypersensitivity. How about us? Maybe we have something different. So we have to discover and not just do the candidate approach. And again, I go back to this word. If you remember anything, it's about collaboration. And now we are currently collaborating with Qatar on a PPM grant. It's a large grant. And here, to make it simple, we are actually doing next generation sequencing on all our samples with childhood leukemia so that we discover genetic polymorphisms that are applicable to us and to the Qatari. So stay tuned for that. But also we need more. This is not it. Okay, if we discover something new, how should we do it? How should we apply it? So let me show you some data. And this article, actually, we published it with Saeed a couple of years ago. What we did here, we looked at the PGX, the Google Scholars, and we looked at the people who do pharmacogenomics research worldwide. And of course, we adjusted those numbers per the population size. And you can see here in blue, that a huge number of the pharmacogenomic experts are coming from high-income country, USA, the West, and very few are from our area of the world. So we need way more experts in this area, and hence the need for education today. And here is Lebanon in here, small number compared to the advanced countries. In that same article with Saeed, we specifically looked at the anticoagulants such as warfarin and acinocumarole. And again, you see that the Western world has done way more than us. The Western world has started way earlier, did so many articles, and then now the Western world is done with this topic. They're not interested in it, whereas we started late and we are still doing some research and we are not there yet. We still need more. We also distributed an international survey, like the survey that Saeed mentioned in Qatar, Saudi, and Lebanon. We did that at the international level. And for the analysis, we differentiated our data into people from the US, from high income and low income countries. If you're interested, you can find the article in 2019. And then when we asked them, do you think pharmacogenomics is important? Everybody said yes. But then when we asked them, do you think this is being implemented in your country? Unfortunately, USA, yes, but either it will never be or it will be implemented after 5 years. So we're not there yet. I don't know if you can see this table, but we then specifically asked them, what pharmacogenomic test do you have? Well, on top of this table are the low-income country, on the below are the high-income country, and you can see here a lot of red X's, and here a lot of green arrows. So that means that the low-income country do not have those tests. However, the high-income country, they do. And then also, just like Saeed did, we asked them about the challenges, and we had a lot of challenges. And again, you can look at this figure in the manuscript. And the data is differentiated between high income, low income, middle income. We had a lot of challenges. Some of them are peculiar to us. Lack of technology, that was asked today, is an issue. Cost of the test is an issue. Suboptimal regulation, people don't know. Insufficient uptake of that. So all of this was there. And you know what? Education would be a great starting point to decrease those challenges, because this is where we start. You educate your students, we educate the regulators, we educate the physicians, we educate the patients. Education is a great starting point, and this is why we are here today. And also, so the survey that I just showed you is an international survey. Well, in June 3, 2023, we had a similar symposium like the one we're having today with BAU. And we have people who registered at the time, 257, and we asked them the question, how much do you know about pharmacogenomics? Look, the majority said a little. So in Lebanon, we have this gap. People don't know much about pharmacogenomics. And then we asked them, how interested are you in learning about pharmacogenomics? Look at that, extremely interested. So this gap is there, and people really want to know more. And we asked them, how interested are you in attending a course or an online course on pharmacogenomics? 50% said that they would be, and here it's a matter of whether they would pay for it or not. And this leads me to that. Dr. Ahmed Wahid already mentioned. This is why we are here, for education, and this huge Erasmus Plus grant, collaborative grant, all of us on that. And this is a very important initiative to start education at the large level, the online pharmacogenomic personalized medicine in Egypt. Also, we all know why we are here today. BAU is launching this wonderful pharmacogenomics and personalized medicine master's program. So this is very good because we need education. And we at AUB, at the same time, we're launching a pharmacogenomics and personalized medicine online certificate. So the difference here, this is not a full master's program. No, it's not. We already have a master's program at the pharmacology department, and we can do pharmacogenetics research. But the difference in this one is that it is fully online. And I fully agree with Dr. Ahmed Wahid. He said from his experience that blended is the best. I 1 million agree with him. Blended is the best. But also it would be nice to have a fully online option for people who cannot come to the university, who are far, who are not in Lebanon, who are in Egypt, who are in Saudi, who are in Dubai, who are in Qatar. That would be a good option. So I'm happy that we have several options for people to actually choose from whatever works with them. And this is going to be launched in April 2025. This manuscript, we published it with Ahmed Wahid recently in Frontier. And here we summarize everything, all the resources, if you want, that are available for us now to start pharmacogenomics in practice, because this is not only about research, this is about practice. And we outline the steps on how to do that in practice. So if you are interested, I highly recommend that you go over this article. And this is actually being cited by a lot of people because it is super useful. What is our aim? We would like to practice pharmacogenomics, and this is an example of St. Jude Children's Research Hospital. For instance, they genotype for so many genes, and then they funnel what is important to them. For them, TPMT is important because they have children with leukemia who are receiving 6-MP. CYP2D6 is important for them because some of those patients are in pain and they may be taking codeine. And we would like to do that. And actually now at AUBMC, we have been discussing this for some time, but I don't know when it will culminate because every time we have a great idea, a disaster happens. So we keep praying. But hopefully we'll have something like that where you can get a report and tell your physician how to change the dose. So this is almost the end. What I showed you is what we have done at AUB, and we are happy. However, we do not work in silo. We collaborate for classic and advanced technology. Now, bioinformatics is a big thing. I am good in biostatistics. I can analyze one gene and one SNP at a time. But when you talk next generation sequencing, this is a completely different ballgame. And again, really, one word is collaboration. I cannot stress on that more. And for that, I thank you for listening. Apologies that I was not with you. If you have any questions or you're interested to know more, this is on my email. You can ask me, you can email me. And I'd like to thank all the people who have been involved in our lab and the funding, all of that, but specifically the Erasmus Plus grant with Dr. Ahmed Wahid. Thank you very much
Thank you, Natalie.
for listening.
Thank you. Everyone is happy with you. Thank you, Natalie, for the wonderful talk and for all the effort you have done throughout the years, numbers and publications talk. I was curious to ask you, don't you agree? We all know that genetic variations, they vary across populations. So to take maybe pharmacogenetics to what we call the next step, don't we need to do the Lebanese Genome Project? This is a question. My second question, I was curious to ask, how do you pharmacogenetically study SNP drug effect in combinational therapies? Thank you, Natalie.
Yeah, thank you. So for the first question, you are 1,000,000% right. And you know, in Lebanon, we have the great ideas, we have the wonderful people, the wonderful know-how, but every time we want to do something, disasters happen. We don't have funding, but definitely, because we keep, you know, you do next generation sequencing side, you do your expertise in ophthalmology, and you compare your patients to the genome of I don't know who. It would be really nice if we do that in Lebanon. And I go back to collaboration. Each one of us does his own thing in his own institution. If we work together, we put our act together, we can do wonders. So that's a quick answer to your first question. The second one, we try. So you will see the articles that are done in Lebanon, for example, in the cancer. A lot of them, they won't tell you that this SNP in with this drug. They will tell you combination chemotherapy, because many times you really cannot differentiate. So even in the cyclophosphamide article that I started with today, the article is not cyclophosphamide. The title is cyclophosphamide combination chemotherapy, because you really cannot differentiate.
Thank you for answering me.
Mhm.
Does anyone have any other question? Do we have questions? No. Thank you, Natalie.
You're welcome.
It was our pleasure and honor to have you.
Yes, sorry إنه مني معكم. Enjoy dinner.
يعني we wish you had. يلا see. لا الآن بتخيل مش هيك هلا.
Our next speaker is Dr. Alain Chebli. Thank you, Dr. Alain, for accepting our invitation. Dr. Alain Chebli is an assistant professor in genetics and molecular biology at the Faculty of Medicine at the St. Joseph University. He is also a head of unit at the Centre Jacques Loiselet for Medical Genetics and Genomics at USG. Welcome and thank you, Dr. Alain.
Thank you for this introduction. We have PDF.
نعمل شير بتخيل. نعمل شير.
Yes, great. Okay, so hello everyone. So in this part of the presentation, I'll be talking about cytogenetics in the era of personalized medicine. So as you all know, cytogenetics is, let's say, an old science. It started in the 1879. We have the pre-bending era, so where some major, let's say, number chromosome abnormalities were detected, especially what's important for us today, because I will be focusing on cancer genetics, the CML and the case of the Philadelphia chromosome in the 1960s. Then we have the bending era, where a lot of structural abnormalities were detected by cytogenetics. And later on, the molecular cytogenetics era that switched all the work in cytogenetics, where the FISH technique and the microarray were introduced. And later on, of course, we have the introduction of the next generation sequencing. But today we are in the cytogenomics era, where we combine all these technologies, whether the classical cytogenetics, FISH, microarray, and the NGS tools with the other new cytogenetic technologies to give a clinical diagnosis and in the research era as well. So in this era, we talk about cytogenetic biomarkers. We know that not all biomarkers are cytogenetics. We have the classical molecular ones, but I will be focusing on the cytogenetics. We know that we have to screen and look for these biomarkers. So we need to know where to look for them and how. So we have some worldwide regulations, such as the European Medicines Agency, that give advices of the inclusion of pharmacogenomic information in drug labeling, where an impact on particular genomic subpopulation is recognizable and provides guidance on the identification and validation of genomic biomarkers. And we know that during the last year, a huge number of drugs was approved, and we need to do some genetic testing before prescribing these drugs. In the States, we know that the FDA takes this part of the work. Oh, guess we have an error here. It's freezing. Freeze. Oh, freezed. Let me see. Yes. No, I don't think so. Yeah, technical issue. Okay. Yes, we have a problem with the PDF. Okay. It's bad luck day, maybe, with all what's happening around us. Okay, so Back to our cytogenetic biomarkers, we know that several regulatory gaps and ambiguities were reported. So there's a lot of gaps in the literature, a lot of missing information, and a lot of problems that needs to be addressed. So a comprehensive registry or database that reflects the various types of available tests across the genetic testing landscape should be available. This is why we need to screen for cytogenetic biomarkers. I guess you all know this movie. So fantastic biomarkers and where to find them and how to find them. And be aware this is subject to copyright, but I will be giving you some tips about this movie. So a quick overview of cytogenetics. So we have the classical techniques, whether it was about karyotyping, G-banding, or R-banding, FISH technique, microarray. What we should all know that there is no ideal technique. All of these techniques have some advantages and some limitations. Classical karyotyping, here we see some examples of a G-banded or R-banded karyotype, will visualize condensed chromosome. So we have this karyotype, this image using a simple stain, GEMSA, just to see the pattern, the number of chromosomes, and the structure of these chromosomes. So it can help in the diagnostic of genetic diseases, of cancers, according to ploidy, so the numbers of the chromosomes, abnormalities, and rearrangements. So let's say the limitations and the advantages. Some of the advantages are the relatively low cost of this technique compared to other molecular techniques or other molecular cytogenetic techniques. It can detect abnormalities of the numbers and of the structures, and it can give also an overview of the entire genome. On the other side, it is time consuming. We need fresh cells for the cell culture. It has this, let's say, we can call it a low resolution between 5 to 10 megabases, and we need skilled and experienced cytogeneticists for the analysis. Here we have an example of a complex karyotype showing multiple rearrangement in a case of CLL, chronic lymphocytic leukemia. So it is highly informative, but frequently not sufficient alone as a sole approach for the detection of complex abnormalities. This is why we need complementary techniques, sometimes FISH, sometimes microarray, or sometimes molecular approaches. As for the FISH, it is a cytogenetic technique developed to detect target DNA. We can do metaphase FISH or interphase FISH. It is applied on fresh tissues, on cultured cells, on FFPE samples. This is why it is widely used also in the pathology lab on FFPE biopsies. So it can be applied in clinical diagnosis. It can be used to guide targeted therapy. Here we have many examples and applications of the FISH, such as FISH for a specific locus, the painting of the chromosomes, the fusions, the telomeres. And we can say the advantages of this technique are it is an easy technique. And when I say easy, relatively to the karyotyping, it is more specific since we have a target. We are targeting a specific region of the genome and less time consuming than the karyotype. On the other side, it is targeted. So we don't have this genome view. We cannot see other chromosomes, other part of the genome, but we see only what we are looking for. As for the microarrays, okay, so for the microarray, so it is a technique developed for the analysis of genomic alterations. We call them copy number alterations for the genomic imbalances, whether gains, losses, amplifications. The advantages of this technique, it is a genome-wide. It has a relatively high resolution, higher than the karyotype. It can reach few kilobases sometimes. It can be done on stored DNA, so no need for fresh cells. We don't need to collect new samples. But on the other side, it cannot detect balance translocation, so balance rearrangement, low cases of mosaicism, and for example, a small clone, a cancer clone, sometimes it cannot be detected if it's less than 20% of the present cells, and it cannot detect genomic position of an inserted segment. So we know we have how many numbers of this segment, we don't know the location of these samples. We have many technologies that are present on the market, most importantly, CGH arrays and SNP arrays. The SNP arrays can provide an additional information regarding the loss of heterozygosity. So our reference is always the ISCN, the International System for Human Cytogenetic or Cytogenomic Nomenclature. We know that the old versions were restricted to cytogenetics, and starting 2016, we have introduced the term cytogenomics, so it can combine the classical techniques and the more advanced tools. So briefly, whether karyotyping, FISH, microarray, these techniques are applied. They have strengths, limitation, resolution, but all these cytogenetic techniques are valuable tools and are used in precision medicine. in combination with, of course, NGS, and as you all know, the newest technology, NGS with the panels, whole exome sequencing, whole genome sequencing, and the CNV analysis with these tools that can give us cytogenetic information. And the new cytogenetic tool that is being widely applied nowadays in Europe and the States, the OGM, the optical genome mapping, where you have these DNA fibers aligned to form this plot, and it gives us information about the number and structure abnormalities. So here in this plot, we see a trisomy 8 has been validated by karyotype and by microarray. So we have this extra chromosome 8. For the precision medicine, I'm going to start with the CML. So it's chronic myelogenous leukemia. And why CML? Because in CML, we detected the first genetic defect linked to a human cancer. So we know in 90 to 95% of CML, we have this translocation between chromosome 9 and 22, leading to this fusion BCR-ABL. And it has a significant impact in precision medicine. In 1835, if we go through the years, we know that the first CML clinical case was reported and described, but until 1960, we didn't know the cause or the origin of this abnormality until the 1960, where they discovered the Philadelphia chromosome or Phi chromosome in CML cells. Then in 1973, it was reported that this Philadelphia chromosome is a result of a translocation between chromosomes 9 and 22. In between 80 and 83, the cloning of the ABL gene was done, but in 86, the cloning of BCR-ABL cDNA from CML cells was done. And since then, we are understanding how BCR-ABL can affect and cause CML. But what is important for us today is that in 1996, it's very important, imatinib, Gleevec, it can inhibit BCR-ABL tyrosine kinase and CML growth in vitro. And then in 2001, the FDA approved Gleevec for CML treatment. So here we can see through the years from a chromosomal rearrangement, a molecular fusion, a target, and FDA approval for this abnormality. And since then, we have the Gleevec resistance, so other drugs have been developed. And we know that this fusion, BCR-ABL, is a tyrosine kinase. It can activate other proteins, and this activation can increase the rate of mitosis and decrease the rate of apoptosis. This is why it's very important to target this tyrosine kinase. Problem. Again. Okay. Fine. So at the molecular level, we know that the 5' segment of BCR is fused with the 3' segment of ABL gene. We have different breakpoint in both genes, so we have different isoforms. We know in the CML, the most frequent isoform is the P210, but another isoform, P190, can cause another disease, the ALL, acute lymphoblastic leukemia. However, what is important to us at the genetic lab is how we can diagnose the T922 in the lab. So at the karyotype level, we can see this translocation between chromosome 9 and 22. We can do other techniques for the confirmation, but what is most important in the karyotype, we can detect another abnormality if it's present. So an additional abnormality, an extra chromosome Phi, and an abnormality on the 17, or another abnormality. By FISH, we can confirm the fusion, BCR-ABL. We can detect if we have more fusion, and we can detect sometimes cryptic cases. And when I say cryptic cases, it's not seen on the karyotype. Sometimes we have CML with normal karyotype. We have an insertion of 9 in 22 or in 22 within the 9. So these cases are detected by FISH. And by RT-PCR, we can confirm the presence of the BCR-ABL RNA transcript. We can detect the isoform, and of course, we can do the monitoring of the disease. And as I mentioned, so Philadelphia positive cells has been treated with the drug, the first-generation drug Gleevec or imatinib. It's a tyrosine kinase inhibitor. So it does not eradicate CML cells, but now we know that the cells cannot undergo blastocrisis, so they will substantially decrease. And we know that the patient who will resist or present an intolerance to imatinib will benefit from what we call second-generation drugs that are currently FDA approved, such as the nilotinib and dasatinib. And this is the flow, let's say. At the diagnosis, we do the karyotype, then we have the complete cytogenetic response. So the karyotype will be normal, knowing that other cells will exhibit the abnormality. At the karyotype, we analyze 20, 30, 40 cells max, but at the molecular level, we analyze thousands of copies of the genes. This is why we continue doing the testing with the molecular biology until reaching the major molecular response or the complete response later on. And recently, studies have demonstrated that TKI discontinuation in CML patients who have undergone prolonged complete molecular remission is feasible and safe, so we can stop the treatment. Quickly, though this is the typical example that I can give CML, but I can give you other examples, such as in AML with the translocation 1517 in acute promyelocytic leukemia. So we have this fusion of PML and RARA, and here, so we can establish the diagnosis, and the rearrangement is critical to begin therapy with all trans-retinoic acid or arsenic trioxide. So for example, for AML, we can do the karyotype, FISH, other molecular study for the isoforms as well. Another example in MDS with the 5q deletion syndrome. So when we have this isolated 5q deletion in MDS, also it will guide the choice of the treatment. When we go to CLL, chronic lymphocytic leukemia, we know that the treatment options for patients with CLL harboring TP53 aberrations, and by aberration, I mean deletions or mutations. Mutation will detect them by molecular biology, but the deletion mainly by FISH or microarrays, so are indicative of treatment that target the BCR pathway or the BCL2 protein. So here we see an example of FISH where we have in each cell 2 green signals, they are the control signals, and 1 orange signal. And the 1 orange signal means we have 1 copy of the TP53. And in this case, we know that 95% of the cases with TP53 deletion, they have a mutation on the other allele. So only 5% of the patients present the mutation alone. For these patients, we need to perform sequencing panels, for example, to detect the cases. Not only in hematological disorders, but also in solid tumors. I will take the example of non-small cell lung cancer, where we have several rearrangements that have been reported in the literature. So we know in 2011, crizotinib was approved as a treatment for ALK positive CLC, and by ALK, the ALK gene that is usually intact will be split and will form a fusion with another gene, causing an aberrant protein. And here, we see the fusion between the orange and green is yellow, which means we have 1 normal ALK, and at the same time, we have the other copy that is rearranged. So this is indicative of rearrangement and has an indication for treatment. And same applies after 2016 with the crizotinib for ROS1 positive lung cancer cells. And here we have the example of a ROS1 rearrangement. We have other drugs generation. And we know that these 2 genes sometimes are tested by immunohistochemistry at the pathology lab. So sometimes we need to do the confirmation when the result is not conclusive. And sometimes the physician prefer to go directly to the genetic testing before doing the immunohistochemistry. And nowadays we perform these 2 genes with other genes by molecular panels. More and more examples. And if I want to go, let's say in details with all the examples, we'll not finish today. So we know that information on suitable techniques for predictive biomarker testing is sometimes not very well provided, especially in regard to new drugs and targeted therapy in oncology. So a focus on the standardization and validation of the pharmacogenetic test will be highly essential. So to indicate what to be tested before each drug, what technique can be used, and the ideal technique, and the most, let's say, cost-effective one. So cytogenetics, is it an old tool? If you look at the literature, you will see that paper that went out like maybe 20 years ago will say that cytogenetic is old, karyotype will be dead in a few years and will not be using it anymore. But we're in 2024, we are still using the same techniques, of course, along with the new technologies. So it's not dead, it's still used for the genetic disorders, for cancers, for possible treatments and personalized medicine. What about the future? So we know that the cancer cytogenetic in the area of artificial intelligence now is booming. So if you want, we can go and check this editorial that we published from the Future Oncology regarding the possible impact of AI and cytogenetics. Of course, it has some advantages and some limitations. So this is my talk, and I'm ready to take any question. Yeah. Yes.
I know you work and you have the next generation sequencer. I'm always curious to know, what does it take to start doing NGS based on your experience to start implementing NGS in clinical practice for personalized medicine of cancer? Why it's not really the things are moving slowly?
I guess the things are moving slowly, not everywhere. In cases of in countries like Lebanon, for example, because we have all these economic barriers. So if you want to sell the test in Lebanon, do it and sell it here. First, you have to collect the samples in order to let it be beneficial for the lab, or at least not to lose money. So you have to collect. So sometimes you will pass the turnaround time of the test, and at the same time, it will be much more expensive than send it abroad. So we know we have many centers in Lebanon that have this technology. So I guess maybe we should do a certain collaboration. So each lab has his, let's say, specialty, whether in constitutional or in cancer genetics. So we can collaborate and make it more beneficial for all the labs. Other way, it will be more beneficial to send the test abroad, do the technique abroad, and you can do the analysis here in Lebanon.
Thank you. Also for regarding NGS, you spoke about the importance of NGS in CNV coding, and we all know that now we are doing paper together, all with three, and the CNV was first suspected to see a few NGS. But what about NGS in determining the breakpoints of the result? Is it really also useful, or it's not that?
I guess it depends on the generation that are being used, but somehow with the newest technology, it is much more precise than what has been done before. So I mean, it's not to the base pair, but it's precise. So we still need to do the confirmation for the base pair. It's not the classical. Maybe here if we are talking about RNA-seq, so we can detect the fusions, and these fusions will be more useful in personalized medicine. I guess so. Because like for the other cases, you don't need sometimes the exact breakpoint. You know that this gene is rearranged. So that's it.
You have any other questions? Yeah. So, yes. Thank you.
Thank you.
Our final speaker is Dr. José Noel Brahim. Dr. José Noel Brahim holds a joint PhD in biology, medicine, health, with a specialization in genetics and cellular and molecular biology from the Lebanese University and the University of Poitiers in France. Dr. Brahim is now an assistant professor of genetics at the Lebanese American University. Thank you for accepting our invitation. Dr. José, the floor is yours.
Thank you. بس على البي سي.
انا لانه مش كونفليكت من ناحيه
لا مش
سوري
مش مشكلة. بس I will share the screen, share the presentation.
مثل ما بدك انت. هون هي نحن عم نسجلها يعني كمان. شو بدك تعال سكرين؟ منيح. بعمل لك اياها شيء.
Okay. Good evening, everyone. So I know you're tired. I will not take a lot of time. So bear with me these 10 to 15, maximum 20 minutes, okay? So today's presentation will focus about how translational research has paved the way towards personalized medicine in familial Mediterranean fever. So what is familial Mediterranean fever, or simply known as FMF? It's a rare monogenic disease that belongs to the family of autoinflammatory disorders that differ from autoimmune diseases by the absence of autoantibodies and autoreactive T cells. FMF affects mainly people originating from the Mediterranean Sea and Middle Eastern origin. And even though it's still considered as a rare disease, it's becoming more and more prevalent worldwide due to large migrations. The disease is characterized mainly by recurrent episodes of fever and is accompanied by joint pain in the abdominal, chest, and joint. And if it is not treated, it can progress and lead to one of the most complications that is known as amyloidosis. Amyloidosis can affect all the organs, but mainly the kidney, which might lead to renal failure. Now, in terms of genetics, the most common mode of inheritance of FMF is an autosomal recessive mode, in which mutations are located on the chromosome MEFV gene that is found on the chromosome 16, short arm of the chromosome 16. And until today, we know that we have more than 396 variants, of whom 62 are pathogenic or likely pathogenic. And as we can see in this figure, most of these mutations are clustered in the exon 10. Now, it's important to note that these mutations are not similar between population and between countries. As we can see clearly here, that these mutations differ, but what we know for good is that the M694V mutation is the most common worldwide, and it's also associated with the most severe phenotype of the disease. Hence the importance of doing genotype-phenotype correlational studies. MEFV, the gene responsible for the disease, encodes for a protein known as pyrene, which regulates inflammation. However, once the gene is mutated, the pyrene protein is dysregulated and interacts with a multicellular protein known as inflammasome, leading to the activation of caspase-1. Caspase-1 in turn cleaves pro-interleukin-1 beta and releases the mature form of interleukin-1 beta, which will be responsible for the inflammation and manifestation of the disease. Since the 1970s, the gold standard treatment for FMF is colchicine, which is administered once or twice daily for FMF patients and throughout life. The treatment is very efficient in reducing severity and frequency of crisis, and usually it works by inhibiting microtubule polymerization, as well as by inhibiting different signaling pathways such as NF-kappa B or NLRP3 inflammasome pathway. Nevertheless, it should be noted that colchicine has some limitations due to its narrow therapeutic index and the presence of potential side effects such as gastrointestinal disturbances. And that's why we can see that around 5 to 10% of patients are non-responders or are considered as resistant to the treatment. Therefore, it's very important to develop for this patient what we call personalized medicine or targeted therapies. Now, studies and translational research have been very important in order to transfer what we know from the bench to the patient. And eventually, now we know that we have different targeted therapies for FMF, including the use of biologics, gene therapy, and epigenetics. So let's start with biologics, or what we call also biologic drugs. They are defined as products that are made from living organisms or components of living organisms. The most important biologics that are used in FMF are IL-1 inhibitors, with their first administration being reported to 2006 and 2007. Since then, more than 30 studies and clinical trials have been conducted in order to investigate and understand the clinical efficacy and safety of these compounds. Nowadays, we know that 2 drugs are approved by FDA and EMA for their use to treat FMF. The first one is known as canakinumab. As you can see clearly, canakinumab is a monoclonal antibody that targets IL-1 beta, therefore blocking its interaction with the IL-1 receptor. It's approved by the Food and Drug Administration and European Medicine Agency, and it's usually administered subcutaneously every 4 to 8 weeks. Whereas anakinra, the other IL-1 inhibitor, is a human recombinant, as you can see here, antagonist or analog, for the IL-1 receptor antagonist. It's only approved by the European Medicine Agency, and it's administered daily by subcutaneous injection. So the first report to show the safety and efficacy of these 2 drugs was in 2006 by the team of Chai, who tried to treat an FMF patient having the most severe genotype, M694V homozygous genotype, and also this patient has the complication which I mentioned earlier, amyloidosis. And surprisingly, they were successful in treating the patient by reducing the severity of the disease, as well as by suppressing acute phase reactants, mainly serum amyloid A and C-reactive protein. After 2006, a lot of studies were conducted, as I stated, but eventually a randomized double-blinded placebo-controlled trial that was conducted on 25 patients that were colchicine resistant also showed that anakinra was beneficial in reducing the number of attacks in the joints, as well as without showing any adverse effects. And this was very important to conclude that anakinra is a safe and efficient treatment for FMF patients that are usually resistant to the standard treatment, i.e. colchicine. As for canakinumab, a study conducted in Turkey by Berdeli and his colleague showed that canakinumab was effective and safe in treating 22 patients. These patients were resistant to colchicine, and interestingly, inflammatory markers were also reduced. Now, it's not only about IL-1 inhibitors, because other inhibitors are also tested for their efficacy in FMF. These inhibitors include the TNF-alpha inhibitors, such as infliximab and etanercept. And these drugs, they act by inhibiting the interaction of TNF-alpha to its receptor, therefore suppressing the downstream signaling pathway. So one study that was conducted in 2007 on a patient that was resistant to colchicine. In fact, this patient was recommended to enroll in the trial to test etanercept, because after he took colchicine, he developed diarrhea, so he was not responsive to the treatment. And etanercept was successful because it reduced all the FMF manifestations. Also, another study conducted in Turkey on 4 FMF-related amyloidosis patients that were treated for long-term with infliximab, and they were followed up for the efficacy of the treatment, showed that a lot of the symptoms were resolved, such as gastrointestinal findings, protracted arthritis, as well as the nephrotic syndrome that was observed in this patient. More importantly, that was the thing that was very important, that the quality of life of these patients increased. In fact, they get rid of getting hospitalized frequently, and they returned either to school or to work. Now, another targeted therapy that is garnering a lot of attention during the last years is epigenetics, and more particularly, how to use epigenetics to regulate microbiota. So if you know very well that the gut composition is very important to regulate a lot of metabolic pathways in our body. So let's think about it. If we can really modulate the gut composition of FMF patients through different supplementations, such as probiotics and prebiotics, or for example, by different strategies such as fecal microbiota transplantation, we can enhance the gut of these patients by reducing inflammation, by increasing antioxidant systems, and therefore by helping these patients to resolve their manifestations and to reduce the severity of the disease. For example, one study that was conducted on a probiotic Lactobacillus acidophilus in FMF patients showed that supplementing these patients with this particular probiotic helped in reducing the number of yeasts, mainly Candida albicans, as well as the abundance of enterobacteria in both male and females. At LAU also, we are trying to study some metabolites that are produced by the gut microbiome. In particular, we are checking for the role of short-chain fatty acids, which are fatty acids of less than 6 carbons. These fatty acids are known to be produced by the gut microbiome through anaerobic fermentation of dietary fibers and non-digestible saccharides. Eventually, what we are looking for is to supplement in vitro and more particularly ex vivo PBMCs from patients, so peripheral blood mononuclear cells. We are extracting them from FMF patients. We are supplementing these PBMCs by different short-chain fatty acids, in particular butyrate and propionate. And we will see the effect of these short-chain fatty acids on inflammatory markers such as cytokines, as well as on the different signaling pathways that might be important in FMF, such as autophagy, apoptosis, or other signaling pathways. Until now, results are very promising, and hopefully it will lead to, at a later stage, some combinatory treatment in FMF patients. Now, microRNA therapy also warrants further investigation because previous reports have found that we have a lot of microRNAs that are dysregulated in FMF patients, and these microRNAs are associated to different signaling pathways, more particularly inflammation, autophagy, and apoptosis. So different research teams, including our research team at LAU, is trying to use some mimics or antagonists to either inhibit these microRNAs or induce the production of these microRNAs, and therefore to see the effect on the above-mentioned signaling pathways. And eventually, if we have some promising data, we will be able to see how this treatment might reduce inflammation in FMF patients. Other teams, on the other hand, are trying to see what is the specific profile of microRNA that we can obtain in FMF patients as compared to controls or as compared to other inflammatory diseases. Once we are able to define a specific profile for microRNAs, we might be using this profile as biomarkers in order to allow a better and more accurate diagnosis of the disease, hence improving the diagnosis and allowing a better management of FMF. Now, currently in France, there's an ongoing microRNA clinical trial that is based on the quantification of a particular microRNA known as MER326. This study enrolled four different groups. In each group, we have 10 subjects that are divided according to their genotype. So the first group in which we have 10 homozygous MEFV patients. So they are genetically and clinically confirmed as FMF patients. We have 10 healthy controls, 10 asymptomatic heterozygous MEFV patients. In other words, they do not have the symptoms, but they have one mutation of the gene, and 10 symptomatic heterozygous MEFV patients. They have one mutation. Genetically, they are not FMF, but clinically speaking, they have the manifestations. And this is very important in order to see how the levels or the expression levels of this microRNA might be different from one category to another category. Once you are able to see these levels, we will correlate them with the genotype of the different patients, and we will move forward to other microRNAs in order to create a biobank that will be very helpful in defining which microRNAs might be used at a later stage as a treatment for FMF patients. Nevertheless, it should be taken into consideration that we have a lot of challenges and limitations that needs to be addressed before applying microRNA as a therapy for patients, not only FMF patients, but all patients in general. So first of all, we need to define which delivery system is the most suitable one, and what is the pharmacokinetic and toxicity of these microRNAs in order to minimize side effects, overcome intolerance, and reduce off-target effects. Now, finally, we know that microRNA therapy, gut modulation, and eventually biologics are used frequently in most of the diseases that we know. But there is another technology that is very interesting, and it's booming since 2007, let's say. This is CRISPR-Cas9. So what about CRISPR-Cas9, and what is in fact CRISPR-Cas9 technology? So I suspected that we might have some students, so I put a video that will present briefly and quickly what is CRISPR-Cas9 technology. We can watch it together. So I think hopefully it will work. I'm not sure. Okay.
Highlight corrected or deleted. Within our DNA, that function is taken on by a system called CRISPR-Cas9. CRISPR is short for clustered, regularly interspaced short palindromic repeats. CRISPR consists of two components, the Cas9 protein that can cut DNA and a guide RNA that can recognize the sequence of DNA to be edited. To use CRISPR-Cas9, scientists first identify the sequence of the human genome that's causing a health problem. Then they create a specific guide RNA to recognize that particular stretch of A's, T's, G's, and C's in the DNA. The guide RNA is attached to the DNA cutting enzyme Cas9, and then this complex is introduced to the target cells. It locates the target letter sequence and cuts the DNA. At that point, scientists can then edit the existing genome by either modifying, deleting, or inserting new sequences. It effectively makes CRISPR-Cas9 a cut and paste tool for DNA editing. In the future, scientists hope to use CRISPR-Cas9 to develop critical advances in patient care or even cure lifelong inherited diseases.
Okay, so perfect. So now we know what is CRISPR-Cas9. Let's think about it. How can we use it? In fact, we can use CRISPR-Cas9 by editing genes, as we saw. And the genes that might be edited might be involved in different pathways or functions, such as cytokines. As I mentioned, these are main regulators and main effectors in FMF. So by manipulating cytokines or by manipulating immune cells, such as Tregs that play an important role in inflammation, now we can correct the imbalance between pro-inflammatory and anti-inflammatory cytokines and therefore treat a lot of diseases. And indeed, nowadays, CRISPR-Cas9 is used to at least not fully treat, but at least to find a treatment for different autoimmune diseases, such as systemic lupus erythematosus, multiple sclerosis, inflammatory bowel disease, and rheumatoid arthritis. But what about FMF? Can we apply CRISPR-Cas9 for FMF patients? Until now, we don't have any study that was realized on FMF, but what we know that yes, if we can edit the genes by eliminating at least one mutation out of the two mutations that you might have in FMF patients, we might eventually reduce the penetrance of the disease and reduce the severity. So this needs to be addressed for sure at a later stage. Now, similar to microRNA, there are a lot of challenges for CRISPR-Cas9 to be applied in vivo and ex vivo. So first of all, we know that most of the studies are now conducted on cell lines. They are not conducted ex vivo and in vivo. And in case they need to be conducted ex vivo and in vivo, we need to think about the delivery system. We need to think about how to reduce off targets. And we need to think about our immune system. So how our immune system will be able to interact or react versus such technology. So all these needs to be addressed before really thinking about how to use CRISPR-Cas9 in vivo and more particularly ex vivo in inflammatory diseases. So before concluding our session, I would like you to take a home message that in spite of all these available treatment for FMF and for other inflammatory diseases, none of them is considered as the perfect treatment because each has its own advantages or limitations. However, we need to understand one important thing. The new era of translational research will allow, of course, the design and generation of new effective and safe targeted therapies and personalized medicine, taking into consideration the patient genotype, the family history, and the environment. So I would like to thank you for being present, and I would like to remind you for one important thing. A disease may be rare, but hope should not be at all. Thank you.
I have one.
No, of course, I think that the molecular diagnosis, i.e. the identification of the genotype, is very important before even deciding to give colchicine for the patient or not. Yes, exactly. The main important reason because physicians, even though they are more and more knowledgeable about the disease, but most of the times the patients are asked to go to the hospital, for example, to do surgeries because they might think that this is, pancreatitis or other inflammation in the body. But once we do the molecular diagnosis, we can confirm the disease, which is FMF. And then, of course, based on the genotype, we can adjust colchicine dosage because you know that those with the most severe genotype will require a higher dose of colchicine as compared to those having one mutation or the two less severe mutations than the M694V. Yes, of course. Yes, in fact, in Lebanon, what we do is sequencing of the MEFE gene, and we can check for all these mutations. In fact, in FMF, we have 400 variants, and we have at least 60 pathogenic, likely pathogenic mutations. So we start with the most common mutations and most severe that are clustered in the exon 10 and exon 2, and then we move forward if we don't see anything to the other exons. And most of the times we do not confirm the result because until today, we are discovering more and more variants that are found in the MEFE gene. Most welcome.
I have a question for Dr. Jose and maybe also for Professor Gabel, who might
help in answering the question, of course.
So how can someone be clinically FMF, but not genetically FMF? Is there any gene other than the MEPFD that might be also causing, is there any novel gene? I don't know.
Okay, so basically, Saeed, what we know, the disease is monogenic. We used to say that it's a straightforward disease with one gene responsible for the disease. Nowadays, we don't consider FMF as a monogenic disease, even though one gene is responsible for the disease. But we know very well that we have a lot of modifier genes, and these modifier genes play an important role in different pathways, such as I mentioned. So the issue in FMF is inflammation. If we can trigger inflammation or reduce inflammation, we will develop symptoms or reduce symptoms. So one of the modifier genes is the IL-1 beta gene. If you have a certain polymorphism in this particular gene, you will stimulate signaling pathways that are involved in inflammation, hence leading to the symptoms of FMF, even if you have one mutation, because this one mutation will predispose the patient to a higher level of inflammation. Yani حتى the cells that are found in FMF patients are already activated, which is not the case of control healthy individuals.
So we need at least one mutation in FMF.
We do not say that there are genetically confirmed FMF patients, but we say that there are, if we have the symptoms, clinically FMF patients, yes. And nowadays, scientists are shifting towards considering even the presence of one mutation as FMF because they are responding well to colchicine. And most of the times, we can see a lot of patients with one mutation responding to colchicine, and eventually they don't have any more a crisis. And this is mainly, most probably, because their inflammation is higher than the healthy subjects. So if you control the inflammation, you will control the manifestations. If you want to add something there, I'm not sure. Okay. Thank you.
Thank you. اوكي في رحمة خلاص نعم ايه يلا يلا طيب يلا طيب بدكم نبلش يلا نائب تفضل ولا Natalie, do you hear us? I don't know if you hear us.
Yes. Hi, are you doing the plan?
يلا لأنه كمان we need to hear كمان your opinion on the matter. So, yeah. لكن
هلا أنا I can only hear you. So
in Natalie phone. In Natalie phone قلت له. So thank you for staying with us. For me, this part is the cherry on the top of all our day. I'm really honored and pleased to gather experts and stakeholders in the field of pharmacogenomics and personalized medicine. We have Professor Laani, Professor Wahid, Professor Mgharbani, Professor Fakhouri, Dr. Saloom, also all of them gathered around one round table to discuss pharmacogenomics and personalized medicine in Lebanon. Also, we speak about Egypt from benchmark to healthcare. So, yeah. And I'm so sorry. Also, I forget Professor Zghaib from AUB, Natalie. Sorry for the issue. So, الانترنت مش عم يزبط. So I will be really speaking very briefly. So we all know pharmacogenomics is a crucial pillar of personalized medicine. Lebanon stands at the threshold of this transformation. However, key challenges exist at the level of regulation frameworks, academic training, clinical application, public awareness, and research. Today, we will explore how Lebanon and Egypt, even with the opinion of Professor Wahid, they move forward in this exciting potential to practical healthcare delivery, making PGS a cornerstone. And we will be starting with a 5-minute opinion, and we will be starting with Dr. Saloum, the president of the Lebanese Order of Pharmacy. نائب أفضل حضرتك. So yes, so Naib would like to know from a regulatory perspective how Lebanon can establish a supportive and legal institutional framework for pharmacogenomics. And I also added a question lately, and in I added a question, what do we need to make PGX test reimbursed or at least cost effective?
أول شيء أكيد هذا الاختصاص هو مهم جدا. مثل ما حكيت من شوي بكلمتي، نحن أصدرنا من حوالي السنة قانون الصيدلة السريري clinical pharmacist. موضوع الفارماكوجينومكس بيتماشى مع هذا الموضوع. clinical pharmacist يعني نحن عم نحكي عن صيادلة أخصائيين على طوابق المستشفيات بكل الاختصاصات والتخصصات. وبالتالي الصيدلة السريري تيثبت حاجته، لأنه نحن اليوم بمطرح بدنا نثبت أهمية الصيدلة السريري بالمستشفى، وأهمية الصيدلة يلعب دور أساسي بالإضافة والشراكة مع الطبيب. موضوع الفارماكوجينومكس كثير مهم بهذا الخصوص، خاصة الصيدلي اللي عامل ماسترز بهذا الاختصاص بيكون عنده دور مميز بالمستشفى، لأنه نحن بنعرف أنه هذا الاختصاص ما بيقدر يمارسه الصيدلي بالكوميونتي فارماسي، ولا يمكن بيقدر يمارسه بدوره از مدراب او از هوسبيتال فارماسيست. اكثر شيء هذا متعلق بموضوع الكلينيكال فارماسي. شغله ثانيه، نحن اليوم في لبنان تم اصدار قانون الوكاله الوطنيه للدواء LDA. هذه الوكاله الوطنيه للاسف اللي طلعت من حوالي 3 سنين صدرت عن مجلس النواب، وبعد ما طلعت مراسيم التطبيقيه تبعها قالوا مثل ما بتعرفوا لبنان بده يضلوا مرق لك والدواء اللي بدنا اياه بنسجله، وبتعرفوا الامور كيف بتصير بهذا البلد. اليوم الفارماكوجينومكس فيها تكون بند اساسي ضمن الوكاله الوطنيه للدواء بتسجيل الدواء بنوعيه الادويه، وتكون الادويه تارجت للمريض. يعني نحن اليوم نعرف انه كل ما يكون هيدا الدواء عنده تارجت للمريض اكثر، كل ما بنكون كمان عم نخفف الفاتوره الدوائيه وعم يكون عندنا نسبه شفاء اكثر بكثير. فبالتالي هذا الموضوع من الناحيتين، كان موضوع الكلينيكال فارماسي اللي نحن اصدرنا قانون بمجلس النواب، LDA اللي صدر قانون بمجلس النواب عنا، يمكن من خلال هيدي البنود نقدر نشرع هيدا الاختصاص، نعمل له ستاتيو معين بقلب الدولة، ويسجل هيدا الاختصاص مثل ما بده يسجل قانون الصيدلة السريري.
شكرا. Thank you. So the second question goes for Dr. Raja. So yes, Dr. Raja, how the Faculty of Health Science and other, let's say, medical related faculties contribute to the advancing of pharmacogenomics through educational programs, especially that pharmacogenomics and personalized medicine are multidisciplinary fields that necessitate the collaboration between scientists, pharmacists, and clinicians. This is first. Second, what does it need to get more scientists working on pharmacogenomics?
Very briefly, first, we need to have curriculum development. and it is an interdisciplinary curriculum development, which means that we need to integrate pharmacogenomics into the pharmacology course, genetic course, clinical practice, and also, for example, and it should be interdisciplinary. I think also we can, for example, as a very important example is the IPE course, the interprofessional application course that we have between our pharmacy, medicine, health sciences, all major dentistry, all these health specialty. So we can have we should integrate the pharmacogenomic in the IPE course, and also for the case study in IPE also we can have the pharmacogenomic also. In addition, we need to have hands-on training and research opportunities. So we need our students to work in the lab on experiments related to pharmacogenomics. We need to have research projects related to pharmacogenomics. Also, we have to have partnership with healthcare institutions, so where our students will do their internship, where they are exposed to pharmacogenomic technique and the interpretation of pharmacogenomic and how to read the data for pharmacogenomics. Also, invited speaker, workshop, example, this workshop today or this lecture series today. Community engagement also, so we have to show the awareness of the importance of pharmacogenomic for the healthcare, all healthcare workers. And also, finally, we need to have continuous professional development program where we can have many sessions on pharmacogenomics. We did many sessions for our alumni. Also, it's very important for alumni and to provide them with certificate and these. Yeah, you asked me the last question.
What do we need to get more scientists working on PGX in Lebanon, for example?
We need to fund them.
Thank you, Dr. Najat. So our third roundtable and stakeholder, Professor Laani. How is your Faculty of Pharmacy specifically fostering the implementation of pharmacogenomics in the pharmacist education?
Thank you, Dr. Regarding the know-how, أعتقد موجود النو هاو بالنسبة للفارماكوجينومكس. الكورسز موجودة available، البروجرامز موجودة. لكن أنا بعتقد إن the most important element is the community trust. المفروض إحنا نخلي الكوميونتي اللي إحنا عايشين فيها تثق في الفارماكوجينومكس وتقبل عليها وما يبقاش في ريزيستنس من المجتمع اللي حوالينا. فبالتالي إحنا محتاجين awareness لهذا الموضوع بالفارماكوجينومكس مش بس على the level of the experts، لا انا بيهمني كمان ان احنا نبقى متواجدين على كل الليفل. اعتقد الدكتوره بروفيسور رجاء شريفه ده اكثر من حاجه مهمه. طبعا بالنسبه لكليه الصيدله عندنا دورنا مع الستودنتس، نقدر طبعا من خلال بعض المقررات الكورسز اللي هي ريليتد للفارماكوجينومكس ان احنا نزود الطلاب بالسكيلز والكومبيتنسز ريكوايرد تو فولو ذيس باث. يعني ده بالنسبه للكوريكولم. بالنسبه برضه للبوست جراديويت احنا النهارده بنحتفل بالسكند انتجريشن للفارماكوجينوميك بروجرام، وبالتالي عندنا قابلنا بعض 4 ستودنت في البوست جراد. الاربعه دول هيكونوا هم الستارتنج او السبارك اللي تبدا تجيب لنا طلاب اكثر من كده، وبالتالي هؤلاء الخريجين لما ينتشروا في الاماكن في الميديكال هيلث سنترز هيقدروا هم they will convey the message to the others. دي نمره واحد. نمره ثلاثه برضه دي اشاره برضه ليها الدكتوره رجاء، معلش لان كان السؤال مشترك، انه احنا من خلال الكامبين يعني احنا عندنا طلاب الستودنتس الفارم دي ستودنتس وعندنا حتى طلاب الاندر جراد في ديفرنت ليفلز. دايما usually they do some awareness campaign everywhere بالنسبه لليونيفرسيتي، بالنسبه للمولز بيروحوا يزوروا كل الاماكن، بيتفاعلوا بيبقى في انتراكشن مع يعني مع السوسايتي او الكوميونتي اللي حواليهم. فبالتالي الاويرنس هنا مهم، لانه في الاخير عشان to implement to proper implement this master of this pharmacogenomic او personalized medicine احنا we need to gain the community trust. فبالتالي دي عمل كبير جدا ان احنا نخاطب الكوميونتي بالمستوى اللي بتفهمه مش بالمستوى يعني العلمي بتاع الاكسبرتس. انا بعتقد ان كليه الصيدله ده دور كبير سواء الاندر جراد او البوست جراد او بالنسبه للكوميونتي انفولفمنت او دي. ثانك يو.
Thank you, Professor. And now the turn is for Professor Galbani. Professor Galbani, all of us know your role and your contribution to the treatment of patients with rare diseases. We would like to know from your point of view how genetics, as a known medical geneticist, contribute to the advancement of pharmacogenomics, and what type of research are most likely to be translated into clinical practice and thus for personalized medicine.
Thank you for the invitation. Actually, for geneticists, it's a new field that we are getting in more and more because we are feeling that it's very much important for our patients. For example, we have a lot of diseases that we can now treat using this type of pharmacogenetics, if you want, and we understood how the pathophysiology of those diseases, and we can work on it more and more closely. And we are doing some very great things using some very basic medicine and treating patients with very, very rare diseases with very basic things like vitamins. And this is very important, and we're very happy with it. So how we are developing, we are helping a little bit the physician by doing some tests, for example, to determine exactly if the medicine is if the patient is fast metabolizer or slow metabolizer for some specific drugs. So we're helping a little bit, but we are still, it's still a poor field of genetics. So what we are doing, I heard the topic from the doctor from AMB, and also Alain, Jose, what they talked about. I felt one of our big problems here in Lebanon is that you are using all the data coming from roads. And we have a very specific genome in our population. So for sure, we need to do some local tests, at least in the Arab world, and work on those Arab tests, if you want, or Arab research projects. لازم الفيلم؟
لا 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 هيدي السسبنس بس هيدي لا لا
كان يعمل هيك زي كان نسهل No. So what you are doing actually, we develop we start with a small test, and now using artificial intelligence, we went further and further, and we had genetic tests in pharmacogenetics where in a simple few drops of blood, if you want a sample of blood, we can screen for hundreds and hundreds of different drugs and determine and classify them directly depending on the research and update those tests and not those the results. For example, if you have new publications, we can update those publications directly on the results. What we are trying to do is not to put those tests very expensive.
Hey man, this is a challenge.
It's not expensive. I think it's still basic. All people can afford it. Most of them can afford it. Although it is for Lebanon, I don't know who talked about, probably Alain talked about the economical issues. It's still difficult for some of the patients, but it's still affordable. And for example, if you need to treat someone with, I don't know, epilepsy, we can do this pharmacotest and screen for all the different medications that can be used for seizures, for example, epilepsy, and give the physician some guidelines about how to use those medications. Do I have to add the doses or to diminish the doses a little bit, you know, if the patient is slower metabolizer or faster metabolizer. We need to do GWAS studies, but it's quite expensive. I don't know where to bring and talking to the deans, because usually deans, everyone goes to the dean and ask the deans for money. And the deans systematically, I don't have. Because when they start to be deans, unfortunately, they jump from the research side to the economical side. And because they have the president of the university, all the stakeholders, the board of trustees, they need to see numbers. 1 plus 1 equal 2. So it's 1 plus 1 equal 1.8 because we did some research on why it doesn't work. So we have these small problems, and we have to ask, and we have to collaborate, and probably ask outside how we can work on it. We are doing now at LEU a huge project. We are doing a whole genome analysis because we started our 1,000 genome project analysis. And we are focusing a lot on breast cancer. So we already have many patients. So now I'm calling for collaboration. So if you want to collaborate, just send me or call me directly. Send patients, it's free of charge. Send patients with breast cancer, and also we will test also people without breast cancer. And we are doing this whole genome just to understand a little bit how and why people are having breast cancer at a younger age in Lebanon, and how we can, from these analysis of testing 1,000 patients and a series of normal individuals without breast cancer, to understand how we can work on this. So we are moving very slowly, unfortunately, but we are moving. So I'm calling now the young scientists. This is their turn. For me, it's I'm at the end of my career. Thanks God. No. It's good. It's good to have new ideas, new brains, more younger brains. So I'm very happy that many people are jumping in the pharmacogenetics, and I'm sure it's going to be very helpful.
Thank you, Professor.
Do it as much as, for example, my mother. You talk probably about non-small cell lung carcinoma. So I did the pharmacogenetics and I did the different tests. Do you know how much the medicine costs? So I'm paying $3,000 per month to treat her. She's good. Without this treatment, she might have died 3 years before. She's okay. Let's say the candle is, losing shway and do shama. But still, that's very expensive. I think is how can people be able to afford it. And we did a study one day, and we found that all over the world, I'm talking about precision medicine and personalized medicine. I can't afford it. I am sure that 90% or 95% of our patients won't be able to afford it. Otherwise, we are privileged
to have
this in our universities. Absolutely, we need to bring our forces together, otherwise it will not.
Thank you, Professor Mgardani. So our next stakeholder is Professor Zraib from AUB. Natalie, what do you think? What are the keys and considerations in implementing pharmacogenetics into routine clinical practice? I know you have worked a lot to integrate PGX into clinical practice, and you had a slide today about what are the actionable SNPs, pharmacogenes specifically, and how healthcare system adapt to ensure effective integration for personalized patient care in Lebanon. Second question, as a stakeholder in Lebanon and the nearby region, what do we need to take PGX research into another level?
Yes, thank you, Saeed, for hanging in there. Well, I want to continue the discussion from what Andre has started. In research, it's fun. We academicians enjoy research, we collaborate, and we work together, and we can do it. It's under our control, relatively. Even though also Andre mentioned that the university needs some numbers, and we can convince them in research. In practice, no matter what we do, you want a mandate from the government, from the Lebanese Order of Physicians or pharmacists to say this is something that has to happen. For instance, in Europe, for example, they were very slow. But then suddenly there was a mandate that you have to do DPYD, genetic polymorphism, for patients taking azathioprine. It's a mandate by the EMA. You have to do it. خلاص. So you do it. In the US, the FDA says you have to do CYP2D6 for tamoxifen, you do it. نحن بلبنان, we don't have this mandate. So شو ما عملنا وشو جربنا, it will always be individual efforts, individual universities. عم نخبط بالحيطان لوحدنا. now. So I would like to put this, إنه you need an overarching acceptance وبالنهاية كمان for insurance companies to pay. بعدين كيف تنعمل بصيروا ديتاي، بدك تفكر أي جين، أي variant، preemptive versus point of care، بدك تعمل panel، بدك تعمل array، بدك تعمل one test at a time، بدك تعمل electronic health records، بدك تعمل clinical decision support. كلهم هدول ديتايل إذا بدك operations. But the big thing is this mandate that I don't see happening anytime soon. Nevertheless, education مثل اليوم وغير أيام بركي بفتح عيون. Of course, clinical pharmacists would have a major role in something like this, and I'm glad that Joe Saloom is on board with us.
Thank you, Natalie. Thank you for also having you on board. For the last, not the least, stakeholder, Professor Wahid. So given Egypt's growing healthcare landscape, what are the major challenges and opportunities you foresee in implementing pharmacogenomics, and how can the country leverage its unique resources to advance personalized medicine? Professor Wahid.
شكرا سعيد. Such an opportunity. الكلام ده فيز 2 بعد ما الفيز 1 يخلص، ولكن الامور مش ورديه بالشكل ده. العمليه بتمشي ببطء مش بسرعه، هي دي كلها برايت بوينتس. ايه اللي بيخلينا بنمشي ببطء في مصر؟ واحد، عندنا مشاكل في الريسيرش زي ما قال الدكاتره، عندنا مشاكل في الفندنج كبيره جدا. احنا طول الوقت واحنا بنهانت جرانتس. عندك مشاكل دلوقتي في القوانين السريريه دخلت في مصر بقى 3-4 سنين، الحصول على عينات محتاج كونسنس واجراءات، ولكن الدنيا بتمشي. في عندنا البيلر الرئيسي من المشاكل او الاوبستكل الرئيسيه هي الاديوكيشن، لاك اوف اديوكيشن. احنا اول بروجرام ايفر في مصر يمكن في لبنان، فاحنا واجهنا مشكله ان الاطباء الفيزيشنز في مصر بيجهلوا الفارماكوجينومكس كتير منهم جدا. صح. فبالتالي هو عنده ريزيستنس، هيقعدوا بقى يجهلوا. لا انا ايه اللي طبق، ما الدنيا ماشيه كويس جدا عندي. فاحنا عندنا مواجهه، بنواجه ريزيستنس قويه جدا. المشكله الثالثه في الايكونومي. انا اتكلمت برضه، لا اذيع سرا، ان انا اتكلمت مع اوفيشالز كبار جدا في مصر، سواء يعني في وزاره الصحه والقوات المسلحه، ان اللي بيعوقنا عن التطبيق الكوست. طيب احنا عشان عندنا لو ميدل انكم كانتري، طيب هيتكلف كام ده؟ طب انا لما عندي 100 مليون في طبعا احنا عددنا 110 مليون، طب هنطبقه فبيتحسب كده دايما. فالايكونومي داخل في القصه دي، بس المشكله الاكبر هي الاديوكيشن. مفيش اديوكيشن، موقف الدنيا خالص، مفيش اويرنس. اخر مشكله عندنا الريجولاتوري افيرز. طب انت عندك خلصت المشاكل دي كلها، تعالى بقى الداتا الضخمه دي كلها مين هيتحكم فيها؟ ما عندناش القوانين في مصر اللي بتضبط ان الداتا دي تبقى تحت كنترول مين او مين هيتحكم فيها الى اخره. لسه ما عندناش البنيه التحتيه التشريعيه زي امريكا وكندا واوروبا. فاتمنى ان الاوبستكلز دي لما شويه شويه تدوب، هي بدات فعلا تدوب بس شويه شويه ان شاء الله لما تدوب الحركه هتبقى سريعه جدا والتقدم هيبقى سريع قوي في مصر.
Thank you. So I believe we are a bit short of time. If someone from the audience would have to ask a question, please go ahead to ask your question. Otherwise, we could.
أنا بس بدي أتشكر دكتور ناتالي يعني ديك المرة بنيوكاسل ما كنت معنا مشان طيارة، وهلا ما في طيارة وكمان ما شفناكي، we will miss you يعني over the dinner، بس إن شاء الله بنعوضها لما ظروف البلد تصير أحسن. Thank you for joining us يعني حتى لو أونلاين بس كنت معنا.
Thank you.
بدي
I
اتشكر
know.
كل اللي شاركوا معنا اليوم. بدي اتشكر دكتور سعيد، اكيد المفروض تكون عن جد بسبب الظروف زملائي الاعزاء كمان تعذبوا واجوا، فشكرا لكم. الدكتور ترك شغله مع انه بالمستشفى بس هلا كلير خلص، هلا كلير يعني بناخذ دينر نحن ومرتاحين، فحتى ما نتاخر اكثر بليز تفضلوا على العشاء.
هلا خلص.
Thank you Natalie.
Thank you Natalie. Wish you were here. Thank you everyone. Thank you also لكل اللي كانوا معنا online.